So this talk, I'm focusing more on the head and neck, thyroid lumps. Thyroid lump is one of the standard station, either in the clinical examination or in the viva or in the communication skills stations. So when you talk about the viva, if you have already mentioned the head and neck history in the head and neck stations, you don't have to repeat the detailed history in the thyroid station. For example, the station comes as a third station. You already mentioned, I'll take head and neck history like blah, 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 swallowing dysfunction and all these things. For thyroid history, what do you take? What history? The history, the most important history is how long is the duration, how fast it has come, how quickly it progressed. So these are the most important thing in the thyroid lump. And also relevant symptoms for the thyroid, for example, can cause dysphagia, and large tumor can cause breathlessness and stridor, and the malignant tumors can compress the vocal cord or involve the nerve, causes hoarseness, and occasionally weight loss for metastatic disease. So these are very relevant for the thyroid. And also the red flag symptoms like extremes of age and kind of female sex or male sex, and family history of thyroid cancer or previous radiations or thyroiditis, for example, Hashimoto's thyroiditis. These are the things a risk for malignancy. So this, make sure you mention these things in the thyroid. These are all the tick boxes for thyroid lump. You can mention other things like smoking, alcohol, and all these things, and but that's for more like a SEC type of thing. Okay, and examination, either if it is in the clinical examination, just follow the pattern like inspection, and then followed by kind of palpation. So inspection is like a kind of where is the lump located, then whether the lump moves with the deglutition or protrusion of the tongue. You're trying to differentiate from the thyroid or thyroglossal cyst, and how far the lump is extending, whether it's going retrosternally or moving across one side to other side, involving the isthmus, or is there any lymph nodes next to it. And and clinically, you might see sometimes signs of hypothyroid. This is more academic, but that's sometimes worth mentioning. Then many people that they talk about these things elaborately, then they forget the vocal cord check. That's why I always tell them, just imagine you are in the clinic room and tell these things first, then you can always top up the other things. So the important things are what you do routinely. So after examination of the neck, you will carry out a flexible nasal endoscopy to rule out vocal cord palsy, and also sometimes there may be some previous vocal cord palsy or new onset vocal cord palsy. That's the important thing. So this is some simple examination. Like this is a multinodular goiter with a mild retrosternal extension. This is a large unilateral kind of lump, and sometimes you may not be able to feel anything. You only incidentally you pick up by the CT or ultrasound scan, and sometimes you have a large nodules as well. Okay, this is an extensive multinodular goiter, and this is not to show this photograph. This is to understand what is the underlying implications in removing this one. For example, airway problems, difficult intubations, and tracheomalacia. These are the things you might have to discuss in your discussions. So that is the reason I'm saying that try to move a little bit forward very quickly, because as I said, you have only 5 minutes, and there are a lot to discuss, particularly about the investigations and management. So you've seen the patient, you clinically examined, taken the history, and they performed flexible nasal endoscopy. Exactly, the examiner will say this one, but you see sometimes the trainees will go back again and again the history and the examination. He said clearly, you've done that, first visit done. You ordered, then you ordered ultrasound guided FNA. So that's what you have to finish at the first clinic. That's what we normally do, isn't it? So you've done the ultrasound guided FNA. So they will ask, why do you want to do ultrasound guided FNA? Why can't you do free FNA? In thyroid, in generally, we moved on from free FNA, freehand FNA. It's mainly ultrasound guided FNA, which is a standard of practice. The reason is With ultrasound scan, you characterize the nodules. You are grading the nodules according to the classification like U1 to U5, and also you can add up how many nodules, whether there's any associated nodes, and whether any abnormal features, which is like kind of irregular margins and increased vascularities and microcalcifications, or abnormal shape. These are the things through that they can kind of characterize the U1 to U5. You all know what is U1 to U5. U4 and U5 is a kind of malignancy. U3 is kind of in between, and U1 and U2 is more benign. So then it's usual to do some thyroid function tests if the GP has not done. Most of the patients had this test done. Calcitonin is the only test we do it for a medullary thyroid cancer, not routinely practiced for other cancers. So then the question is more about thyroid FNAC, which is 1 to 5. Again, you need to know what is Thy 1 and 2 and the local protocols or British thyroid guidelines protocols. So generally 3 and beyond, all these patients are discussed in the thyroid MDT. So mention that word and then either go for a diagnostic hemithyroidectomy or total thyroidectomy, depends upon the circumstances of the patient and the recommendation for from the MDT. So many patients undergo thyroid diagnostic hemithyroidectomy. It's mainly for if the lump is less than kind of 4 centimeters in size, if you think that's the only treatment, and even if it is a malignant. Some patients or some delegates, they say, oh, Thy 5, then I'll do total thyroidectomy. It's not necessary. Thy 5 means it's malignant. If it is small, that can be only hemithyroidectomy is more than enough for these patients. Yeah, and they think about the complications, which includes all other complications like hematoma, bleeding, and all these things. But the important complication is recurrent laryngeal palsy. So how you, sometimes the question is about how do you do thyroidectomy? So, sorry, Sri, I'm lecturing, yeah. The most important thing about is what do you do after that? So again, if there are concerns, you go to MDT with the post-op features. For example, adverse features includes kind of messes like margins, close and multifocal things, and high risk factors, for example, age or aggressive tumors like poorly differentiated or the tall cell variant. These are the things patient will be considered for the completion thyroidectomy. Some cases in advanced tumors like anything beyond T3 N1, patients also go for radioiodine treatment as well. And it's worth knowing few ongoing trials, and which is currently a heart trial, which is hemithyroidectomy or total thyroidectomy, just about to start for low risk cancers. ION trial, which is whether iodine post-op radioiodine treatment is necessary or not for intermediate risk. So they categorize into early cancers, intermediate, and advanced cancers. So according to that, the treatment is kind of planned for that patients. So the bottom line for the thyroid patients, why ultrasound guided FNA? And what are the clinical tests you do, and when do you discuss in the MDT? And the FNAs is like different categories and complications of thyroidectomies, and the treatment protocols if you're really doing well, and some of the discussion about the trials and all these things. Yeah, okay. So moving on to the parotid, it is again focused history. Which related to the onset, duration, progression, aggravating and relieving factors, for example, food or recent infections. It's just rule out silodinitis. But for the parotid, the most important, not missing ones are facial weakness and previous skin cancers in the scalp and the temporal area. And these are the kind of main important things. In the examination, mainly you do examine the parotid, but the most important things are any lymph nodes next to that area and previous skin cancer excision in the temple or in the cheek and the scalp areas. Examination of the oral cavity is very important. For example, deep lobe of the parotid limb tumor, always push the tonsil medially. That actually they might show you the picture similar to the quinsy. It is not a quinsy, so it is a deep lobe parotid tumor. Okay, and examination of the facial nerve, all the branches. It's very important, especially for it's sometimes you see the patients in the examination stations. They will have some faint scar, a modified bladder incision, which has been done 15 years ago, and so it is really kind of faint. All you see is a very shallow area in that area. Then the facial nerve, many will examine. That's good, but some of you will miss the facial nerve examination in this examination station. There may be some mild weakness when they smile. So it is important to examine in a methodically and systematically, and assuming that just don't go with a judgment. That's the important thing. Sometimes the parotid lumps, especially the tail of the parotid lumps, always confused with the level 2 neck node. So the examiners will give you, you can still practically say that it could be level 2 lymph node, I'm not really sure, or it could be tail of the parotid lump. So in many cases, even in real clinic situations, you will come to that dilemma. So there's no harm in that. In that case, you always go for further radiological investigations. You do FNAC in the clinic. So this is the standard is pretty same. So when you take in the history, then the next question is, after the examination, you try and do some investigation. Sometimes if you're unsure, is it tail of the parotid lobe or level 2, you have to examine as a neck lump, which includes flexible nasal endoscopy or other detailed examination of nasopharynx, larynx, and all these things. So in my practice, parotid lumps, I do FNAC as a freehand in the clinic. In some centers, they do still go for ultrasound guided FNA, which is possible. And the reason I do freehand FNA is there is a delay for like 4 weeks for ultrasound guided FNA. So that's why I do it. And I always go for MRI scan for the parotid lumps. The reason is some centers they don't do, but the recommendation is more for MRI scan. The reason is it gives you a realistic image when you plan for a surgery, and also it gives you if there is any deep lobe of the parotid tumor extension, and at the time of surgery you can plan very well. And the most importantly, sometimes they comment about the margins, and then there may be some metastatic neck nodes. So these things could be anticipated beforehand, so you can consider like parotidectomy with the neck dissection in prehand. You can consent the patient before as well. So or sometimes if that's come back post-operatively, if there is a tumor, then you can go back and see the MRI scan in the discussion, particularly in the MBT scan. So some centers ask for a CT scan as well. But if you suspect preoperatively there is a tumor, that's slightly different. So preoperatively, for example, the patient has got a skin involvement, facial weakness, and you straight away ask for proper staging scans, and you plan the operation according to that, and you discuss the patient well before the MBT. So the scenario is either a benign assumed parotid, you go for surgery and you get a benign lump, that's fine. Or you assume the benign lump, FNAC is also benign, but when you do the surgery, superficial parotidectomy, that turned out to be malignant. Okay, that's another scenario. And other one is, as such, it is a proper malignant parotid lump. So these are the different scenarios. See, so they could ask you why you need to advise surgery for the pleomorphic adenoma. The reason I normally say to the patient is, yes, it is considered as a benign, likely, and the most important thing is we approved it by FNAC, but the FNAC has got a 10% false positive or false negative, and sometimes it's easier to remove when it is small. The complications are relatively less, and sometimes these lumps over the years tend to grow, and also there is a small chance it could become a carcinoma of pleomorphic adenoma, and then that is has got a worse prognosis. So these are the things that is the reason we recommend surgery. So they might ask you about the complications, and they will ask you sometimes about how do you find the facial nerve, for example, what technique you use, like tracheal pointer, then superior border of the kind of digastric muscles and mastoid groove, and sometimes retrograde dissection. I use the facial nerve monitors, and these are the things you may have to say. And so once you've done these things, that's come back as a kind of SNXL carcinoma. So in that case, it is a kind of tumor. So in these circumstances you discussed in the head and neck cancer meetings, and also arrange some staging scans to make sure everything is okay. If it is low grade, you could discuss that as a conservative management, regular follow-up. If it is high grade, sometimes they may need adjuvant treatment, or sometimes they may need kind of revision, parotid surgery with a neck dissection. So these are the things you need to discuss in that station. So see how much discussion you need to do it in last 3-4 minutes. So that's why sometimes it's worth progressing more smoothly in the early 30 seconds, then you can have more discussion in the real subject. Suppose the parotid case with the facial nerve is sacrificed already, or facial nerve is damaged. In that case, the surgical management is very different. For example, they have to plan this operation in a more mature way as a consultant. So that's what they are looking for in this exam. After you pass the exam, you're very close to become a consultant. So first of all, when the facial nerve is injured, or traumatized, if the facial nerve is involved by the tumor, you need to assess the tumor. For example, whether there is complete weakness or partial weakness, whether this patient facial nerve can be preserved or sacrificed. Okay, if I'm preserving it, is there any adjuvant treatment we are planning? Or if the nerve is sacrificed, how I'm going to reconstruct? Who are the persons that are going to help? For example, you have to do nerve grafting, so you use a plastic surgeon. Sometimes the vertical part of the facial nerve needs to be mobilized to get extra length, so you need to get the otologist to drill the mastoid, and also keep the histopathologist on board for the frozen sections. You need to resect for the tumor-free margins of the nerve so that you can anastomosis. So then this is nerve grafting, but sometimes you may have to do a combination of both. For example, eyes and the cheeks are the most important, so you have to put some gold weight to protect eye, or facial atlas sling, or sometimes dynamic transfer of the muscle transfer. These are the things you have to plan for certain cases. So this is, you can clearly see this facial nerve weakness and the large lesion, and this is a previous scar. So it looks like this is a tumor recurrence with a facial palsy. So what they have done here is, after resection of the tumor, they have used we have used I think temporalis flap for rerouted for one to the eye, one to the lip. And this is my plastic surgeon helped me for this case. Yeah. So that's about the parotid. So the next one is the laryngeal stations. So you can laryngeal stations, which includes either dysplasia or carcinoma in situ, or actually a malignancy in the larynx. So when you describe this one, there is a white patch always extending from the anterior commissure of the one card all the way to the posterior commissure, and whether it is involving the ventricle, whether you can comment about the subglottis, and you have to comment about the vocal cord movements, so that you can say that that's the important bit. You or some of you forget these things, because that is one of the clinical staging, and that's a common question we ask in the MDT, whether the vocal cord is fixed or mobile. Yeah, that takes you to T3 straight away. So you always think about the worst scenario, that makes you as a safer doctor. Okay, it can be a mild dysplasia. It might look kind of white patches. If you say straight away it's mild dysplasia, I'll manage them conservatively, ask them to stop smoking, which is right, which you may be right, but please express your concerns. This is looks like something could be sinister. I want to rule out, or at least I want to rule out something sinister. So I would consider taking biopsy, particularly biopsy in the different sites, more deeper biopsies. Then they'll come back and say the first biopsy is mild dysplasia. There's no harm in saying that close observations and repeat biopsies, because even in real life scenarios, we miss the tumor, underlying tumor. The question is whether you need to CT scan or not. It's an easy answer. Most of the MDTs now recommend CT neck and chest for laryngeal tumors. For the T1, well-defined T1, you can say that I can see clearly all around the tumor, and I can see even the undersurface, the flexible endoscope. In that case, I can, if I think it's a convinced, but this case, it's just going in between the ventricles, so you can't get a good view, so there's no harm in asking for the CT neck. And more or less, all the MDTs now for QPI and auditing purpose, it is mandatory to have a CT neck and chest for to rule out kind of staging issues and or rule out other malignancies. So there's no harm in doing that, and whatever your center of practice, you can defend that one as long as it's reasonable. Yeah. Okay. So, and the other few important things are like photo documentation. Suppose if you're following the patients, it's important to review and compare that with the previous photographs, and obviously risk reductions and silent reflex and smoking. So the reason for further treatment is some severe dysplasias considered as a T1 and treated as a T1. Some mild and moderate dysplasia, it just progress over a period of time, it's become a kind of cancer. So the treatment is depends upon whether it is focal or diffuse. For example, if there is recurrent, again, put these things in the MDT or with a surgeon who has got a specialist interest in laryngology and head and neck, might be able to help with this situation. So if it is a recurrent and focal carcinoma in situ and severe dysplasia managed as a T1, and the debate between laser surgery or radiotherapy. So the radiotherapy is considered if they have kind of few recurrences and continue to have risk factors, and they have risk for the GA complications, and there's no options of laser service of the patient preferred. But the recommendation is transfer laser surgery. But if it is like a diffuse and both vocal cords and anterior commissure, still it's possible. But in your center, I think that the best option would be still, if it is limited on one side, you can manage that with the laser. But some advanced centers, they do manage bilateral vocal cords and anterior commissure in a staged manner with a so it's not a contraindication as well. So we talked about two different things like early and now early cancers and late cancers. Early laryngeal cancers, the three different options: transforaminal laser surgery, radiotherapy, or partial laryngectomy. Partial laryngectomy is still commonly practiced in Europe. It's very few centers in the UK they do that. Majority of them is T1A and probably B is treated by transforaminal laser surgery in UK, and radiotherapy is still an option for patients as well. And the merits and demerits has to be discussed. Laser surgery is economical, quick, and convenient. You can repeat as many as times. It's a reasonably good voice outcome, but for anterior commissure lesions, the voice maybe have a slight edge over the radiotherapy. Having said that, the anterior commissure is a large area. It's whether it is involving the muscles underneath in the anterior commissure that matters a lot. If that is only superficial anterior commissure lesion, still best treated with the transforaminal laser surgery as well. Okay, this all is anterior commissure, T1A lesion, which are treated by transforaminal laser surgery. Again, this can be managed by laser surgery, radiotherapy as well. Okay, this is anterior commissure lesion or bilateral lesion. And this again could be treated by radiotherapy or surgery as well. But all these patients are actually in my center treated by transforaminal laser surgery. And this is T2 advanced, which is again, many centers would advise radiotherapy. And this particular, all the cases again, in my center treated by transforaminal laser surgery. This is T3. This one is a radio-recurrent T3. And this one is T3. This went for chemoradiotherapy type of thing. And this T3, this went for a transforaminal laser surgery because it's a radio-recurrent. And the other option was total laryngectomy. But I have removed a partial. Can you hear me?
Yes.
Yes,
Yeah.
I can.
Yes.
Yes.
Brilliant, because it said your internet connection is unstable. Okay, thank you. Right, and so early laryngeal cancer, we discussed about how we manage, and you can read a bit more. This is one I have written in the Elephant UK. So cordectomies types, sometimes you do perform very well, like different cordectomies, 1, 2, 3, 4. It depends upon how much you are resecting, is like epithelium, or this is these are all different techniques. And the voice quality is good as well. So the confusion mainly comes in the advanced laryngeal cancer. How do you treat? In my view, there's no confusion for a T3. In T3, the motivation is to preserve the organ. So the best way to preserve the organ is, at the moment, is chemoradiotherapy in this country. So all the T3 is managed well with chemoradiotherapy. If that fails, for example, 3 to 4 months later, they do a recurrent, any recurrence or something like that, that managed by salvage laryngectomy. Unless the patient has got a dysfunctional larynx. For a T4, most centers offer multimodality treatment. For example, primary surgery, like then chemoradiotherapy or radiotherapy, depends upon the discussion in the MDT. For example, closed margins or aggressive tumors, for example, with a neural and vascular invasions and multiple lymph nodes. So that is the discussion you can have. But some centers, even for a T4, they could offer organ preservation treatment. For example, chemoradiotherapy to start with. Then, if there is a good response, they continue. If not, they go for salvage laryngectomy. The discussion is, yes, the organ preservation is good, but just make sure, according to the previous studies, 1/3 of the larynx become dysfunctional, or it might be already dysfunctional. For example, T4 tumors, patient may not be able to swallow already, or they may come with a stridor. In that case, already it's a stridor, chemoradiotherapy going to make it worse. And so they might end up with a kind of dysfunctional larynx because they can't swallow, they can't breathe. So that's an important discussion you need to mention, for example, and the clear discussion about salvage laryngectomy complications, which are higher, and this time they need a flap, free flap, to minimize the esophageal or fistulas. So what mentioning about EOTC trials or not EOG trials and veteran study, that's what they're pushing for, kind of organ preservation. Yeah. So pet neck trial again, for a post neck dissection. Previously it was a standard, now mainly it's PET CT. If the PET CT is negative, it has got a high predictive value, so you don't have to do anything. If it is PET positive, then the patients go for post-operative or post-chemo neck dissection. Okay, so other discussions about the neck lumps, for example, the rare tumors like carotid body tumors. It's very common to have this one in the examination station because these patients are sometimes managed conservatively as well. You will get this in the exam case. This is kind of carotid body tumors. You can see that 40-year-old lady. It's a diffuse lump for kind of 3 years. And if you take the close history for that patient, her sister had a pheochromocytoma, mom had some spinal paraganglioma. So that is the true history I'm giving. So in this case, it gives you a hint that we are talking about some kind of familial paragangliomas. The surgery, we done the carotid body tumors. I did it with the vascular surgeon. I don't know whether you can see that's kind of hypoglossal nerve, which was kind of stuck to that. We kind of released it, and the vagus nerve was kind of underneath. That was kind of released as well. So the reason I'm saying that it has got some implications in surgery as well, that all needs to be discussed with the patients, especially with the decision making. And this is MRI scan. You can get that in the radiology as well, like kind of salt or pepper appearance and flow voids. The most important point is how much it's displaced the internal and external carotid artery. So you can see that one, and how much it kind of surrounds the internal carotid artery. That's the Chamberlain's classification, because that's what surgically it's important. If it is surrounding 360 degrees, it means it's kind of stage 4 or 5, which you can't resect it. If it is less than 25%, that's where the grading classification starts. So, and also how much relations with the hypoglossal nerve. So sometimes when you ask for the classification, you don't have to remember everything. At least you know the concept of classification is important. So the bottom line here for paragangliomas, it can be genetic, runs in families. It can be functional, and it can be bilateral. It can be multiple. So it's called a 10% tumor. So think about these things. So you need a genetic counseling. You rule out these functional problems with endocrine and MDT, and sometimes get a radiologist opinion to do the functional scans, MIBG, and offer different treatment options. Many of them, they present like 70s, and they have some incidental findings, like, for example, the last of mine patient presented with the snoring. Then we saw the large oropharyngeal fullness, which extending down. So then further investigations showed like 6 centimeters. Apart from that, there's no symptoms. The other patient had a tinnitus, was worked up by the otologist, then had a scan. So none of them actually as a symptomatic patients. So it can be managed conservatively, means by serial scannings and all these things. Yes, surgery is possible if there is a kind of well-defined young patient who is highly motivated. So involve the vascular surgeons and think about the complications, injury to the carotid, the cranial nerves, dysplasias. So these are the things important. Stereotactic radiotherapy is one of the treatment. It doesn't cure, it just keeps it under control. It doesn't give you the diagnostic specimens. But after stereotactic therapy, the surgery has become virtually impossible because of the other things. So these are the things you need to discuss. So it's worth knowing this, your regional centers, so that you can say authentically that this is what you do. That's what the most important in the exam answer is. It's You don't need to copy me what I'm saying. So you need to come out with a very personalized answer. That's how the examiners they like. Okay, for example, in our region, the stereotactic center is Edinburgh. There are some centers in different areas, like I'm sure it's Sheffield when I was trained. So this is that's how it works. Checking about the time. Okay, so unknown primary is another confusing topic, but at the moment it's all very clear, so you don't have to worry about this one. But I request all of you to spend some time to find about the management protocol. So it's unknown primary. The name itself says there is a tumor in the neck. You're searching for the primary. Okay, but we all know the primary is more likely it's going to be a tongue base or tonsil. And also we know the primary is very small. Sometimes it's undetectable or it gets lost in the when we do all the procedures. Okay, so it can be other areas also. So it can be the nasopharynx or the piriform fossa. It's less likely, but it can be. So these are the things you need to keep that in mind. And we also know that we can see the primary sometimes we can't see. Sometimes we have to use some special scans, for example, MRI or PET-CT. Sometimes we have to use some special devices to take more tissues. That's where the NBI sometimes comes in a place, or tongue-based mucosectomy, either robotic or freehand. These are the things. If you understand this principle, that's fine. And the next thing you need to understand is sometimes they say the secondary is there as like a cyst. So it's, don't believe that one. You don't believe that unless you're really process of elimination. So it's a cystic lump which you're trying to prove that is a tumor. If you proved it, that's fine. If not proved, again, you have to try and prove it by surgical excision along with addressing the primary. So that's the kind of, I'm just giving you an overall view about how to manage this one. So the first and foremost, history, expanding a neck lump, and good examination, searching for the primary clinical examination, like nasopharynx and larynx and pharynx and all this tongue base. This is what you see. Sometimes even palpation of the tonsil and tongue base is sometimes helpful. So try and do FNAC in the clinic. If that is negative, try and do ultrasound guided FNAC or co-biopsy, which is more reliable and gives more hit rate when compared to the freehand. So you can do that one. But if it is cystic, that's where the trouble arises. Because of the cyst, you can't get aspirate. Still, there is a possibility ultrasound guided FNA, they can target the solid component of the cyst. They might give you that one. If you get the positive results of SCC, then your next role is searching for primary, which is you can find it, that's fine. If you don't find it clinically, you're going for MRI in most of the centers, but still some centers do the CT, which is it is also equally local practice. Then if the imaging shows there is a tumor there in the tongue base, then you go and take a biopsy, and that's simple and proven. That's one sorted. What happened if the imaging doesn't show the primary, but you have proved a SCC in the neck, then next you go for a PET-CT. The reason for the PET-CT is 1/3 of the tumor is primary. You can detect that with the PET-CT because of the high metabolic activity in that case. So that's why we try to do it before the biopsy, because the biopsy causes inflammation that can confuse the PET-CT finding. So the recommendation is straightforward. If you don't find the primary, either clinically or primary radiological investigation, for example, CT or MRI neck, so its direct recommendation is PET-CT in most of the centers. If the PET-CT is detected, you go and take a biopsy, that's good. If the PET-CT also not showing anything, that is why now you have a special devices, for example, robotic tongue-based mucosectomy or transoral laser tongue-based mucosectomy or something else. like NBI one. So it's all, and the most important thing is bilateral tonsillectomy. There's a minimum operation you have to do for unknown primary. Then it's become true unknown primary if you don't detect it. So that's the kind of travel you have to do. So the next question is, sometimes next scenario is you find a cystic neck clump, you've done the FNAC or co-biopsy, and then you struggle to prove psychologically that is the case. So in that case, you either, even though you think about the branchial cyst, but you are not thinking in that way, because your suspicion is going to be ruling out malignancy. In that case, I would consider either excisional biopsy of that lump. So and that if that come back as a CC, then you think about, you start that again, further management, for example, finding out the primary again, and or sometimes you can do combine the both procedures, like excision of the neck lump along with the pan endoscopy and biopsy of those certain areas, even tonsillectomy if necessary. It's more a discussion with the patient, like what they really want. But unfortunately, these patients, sometimes there is a delay, and because we are following a systematic manner to find the primary. The reason to find the primary is, if you find the primary, first of all, the doses, the chemoradiotherapy doses can be targeted in that area, so there is a good chance and the side effects are going to be less. That's the idea of these things. Okay. So remember, these patients are non-smoker, asymptomatic, and so HPV is a main cause for these patients. The prognosis is very good and basaloid, and there is a lot of trials are coming up whether to do treat them with the chemoradiotherapy. Mainly it's treated by chemoradiotherapy, but increasingly more other treatment options are coming out. For example, transferal robotic surgery with the neck dissection, transferal laser surgery in some centers like Liverpool is a very common to treat this with a surgery and give some radiotherapy at the end to minimize the chemotherapy side effects. So some of the trials, ongoing trials, is PATHOS for HPV oropharyngeal cancer T1 to T3. They start with the transferal robot surgery, neck dissection, then they stratify according to the risk factors, then the low risk, no treatment, intermediate risk, small dose radiotherapy, high risk, radiotherapy and chemotherapy as well. Okay, so I think that's it at the moment from my perspective. Any questions?
Jai, I have one question actually.
Yeah.
The mild and moderate dysplasia in the exam, how do you answer about the follow-ups? Because sometimes they give different scenarios, like sometimes risk factors like a smoker or completely excised, or how long you are going to follow, 6 months, 1 year, or lifelong. This type of scenarios, how do you answer that questions?
That's good. There's no standard guidelines for following up dysplasia patients in UK, but they are trying to develop one. The ENT UK consensus is coming up actually. In our centers, mild and moderate dysplasia, I just follow them up for like 2 to 3 years. Then if the patient has got no risk factors, I discharge them. And severe dysplasia, we follow them up for as like a T1 cancer.
Yeah, thanks.
Great.
Can I just ask one question as well, please, Jay? Was the classification of dysplasia changed to low, high rather than mild, moderate, severe in 2017?
Say that again.
Wasn't the classification system for dysplasia changed in 2017?
Yes, that's it is again similar to the consensus statement. Many uses the L-Ju-Abana classifications, and others use a local classification. Yes, it's worth reading that one. And if we follow a pathology classification recently updated from Royal College of Pathology ones. So it's slightly variable as well. That's why they struggle to get the uniform view of follow-up as well. Yeah, great.
Thank you.
Good. Excellent. And I'll check those.
One more question.
Yes, please.
In case you do pan endoscopy and you do a you're planning a neck dissection for unknown primary, and you are still not able to get that primary source, then how do you cover that the sites in the radiotherapy?
Say that again, please. I got your question, but I want to get that clear.
Basically, when you know that it is an unknown primary and you're treating the neck, and do you cover, and how do you if you don't find it the primary source, then what sort of treatment do you do for covering the covering the nasopharynx and the primary in the radiotherapy regime?
Yeah, absolutely. I think you got the answer right. I think so. If you find the primary, they put the 60 gray dose in the area, then they reduce it gradually to 50, 40 in the remaining areas and all this thing. If they don't find the primary, they assume the primary is starting from the nasopharynx down all the way down to the clavicles. So all those same 60 goes all around it. But some oncologists, they try to modify. If you assume that is a HPV positive tumors, they try and kind of focus more dose on the oropharynx and the tonsil region, and it's maybe minimizing the nasopharynx region. But conventionally, if there's unknown primary, it is total mucosal radiation type. Good. I'll check. Where is Syed here? Syed Iqbal, Syed.
Yeah, I'm here. I'm here.
Oh, brilliant! Thank you. I can hear you. So next is Iqbal. Is a Edinburgh ENT consultant, very knowledgeable, and he has got extensive practice in otology and advanced otology, neurotology. Do you okay to share screen, please?
Sorry, I'm trying to see how I can upload my presentation.
Yeah, you just share screen.
Right. And so I've got my presentation on my desktop.
That's okay. You just share screen, click the green button.
Yeah, and
again, you have to confirm that again. So what is it happening when you click the share screen button?
so you've got basic, advanced, and then files.
No, is the screen, is there any option comes to screen or desktop or something like that?
And there's no option for that, so I'm wondering.
Or is there any, your opened Microsoft PowerPoint also comes in option? So it's a basic, yeah, it comes in a basic, isn't it? What is that top left corner shows? Is it already highlighted with the blue?
1 minute, hold on. I'll just see what's going on here. Yeah, I'm struggling to get this. So it says choose a Dropbox file, which is not correct.
No. You said a basic and advanced, and that's correct, the basic. Then
No, I've lost that screen. Hold on.
it's okay. Press the share screen button, which is a green upward arrow.
Yeah, hold on. Let me just start again.
Yeah. If not, you can send it to me.
Yeah, but how will I control it?
I can forward it. I can advance it for you. It's not a problem.
Okay, hold on. I will just email that to you.
Yeah.
Okay, I have just emailed that to you.
Okay. Yeah, okay. Just give me a moment.
Completely lost the screen now.
That's okay, don't worry. Why did you rejoin it? It will work.
Yeah, that's what I'm going to do. I'm just going to.
Yeah. I got your PowerPoint. I'm going to open that. Yeah.
Okay. Yeah.
Okay.
Okay, I can move these slides, right?
No, you can't. I will move it. You just
move
say,
it.
yeah.
Okay, that's
Okay.
fine. Okay, guys, my name is Iqbal Syed. I'm one of the otologists and skull-based surgeons in Edinburgh, and I am going to give you some pointers on CSOM and CP angle lesions. Now, this is not an exhaustive talk, so I'm just basically going to cover the gray areas and the controversial areas in the topic. We're not going to go through the pathophysiology of CSOM and how it's diagnosed and how it's treated, and you should already know that. Okay, so can we go to the next slide? And the next one. So I'm going to start off with, how we classify CSOM. Can you keep clicking, Jay? So there are various ways of classifying CSOM, and the old way used to be the safe and unsafe ear. Now we don't really use that, and the reason for not using that is, George Browning's research from the 1980s showed that even with a central perforation, you can end up sometimes with intracranial complications. So this classification is really out of date. Next. Again, tubotympanic and atticoantral, you can use that. That's pretty helpful. But the modern way of classifying CSOM, next, is using mucosal and squamous. So when you're talking about active mucosal, you're talking about a central perforation that is discharging. When you're talking about inactive mucosal, you're talking about a dry central perforation. And if you have a heel perforation, you call it mucosal healed. Next. And similarly with squamous disease, if it's a cholesteatoma, it's active. If it's a retraction pocket, it is inactive. Next. So we move on to the role of CT scan for cholesteatoma, why you do it, what you're looking for. This often comes up, can come up in the clinical scenarios. It can come up in the VIVA scenarios. Next. So senior consultants may or may not feel the need for doing a CT scan, but as a day one consultant, you have to find justifications for getting a CT scan done. Okay. So the first one is really looking at the anatomy and variations in anatomy. So what you're looking for is there a destruction of scutum, destruction of ossicles? Is there erosion of the labyrinth, erosion of the bony canal wall of the facial nerve? High jugular bulb, low sigmoid sinus, forward-lying sigmoid sinus, low-lying dura. And how does all this help? Next. So it basically helps you plan your approach, okay? So for example, if you've got a very large pneumatized mastoid cavity, if you do an open cavity or a canal wall down, you will end up with a very large mastoid cavity that is likely to have chronic discharge. Whereas if you've got a very tight mastoid space, so you've got a low-lying dura, forward-lying sigmoid sinus, and you've got extensive disease, you may consider taking the canal wall down. Next. And whilst you may expect a labyrinthine fistula in every patient, it's important, if you see that on the scan, it helps you consent the patient better. The chances of a dead ear are higher if you've got labyrinthine fistula. So it basically helps you in the consent process. Similarly, for the facial nerve dehiscence, the chances of injuring the facial nerve are slightly higher, as well as it helps you in planning. So if you've got a junior doctor who's doing part of the operation, you're a bit alert, knowing that there is already dehiscence of a part of the facial nerve canal is dehisced. Next. Similarly, in finding soft tissue abnormalities, so if you've got an erosion of the tegmen, for example, on the CT scan, you may consider getting an MRI scan done to exclude a meningocele or a meningoencephalocele. And if this is quite large, you may consider a joint operation with the neurosurgeons to repair that defect. Next. Now, as far as revision cases are concerned, cases that have had mastoid surgery done years ago, you don't really have any notes. There are few landmarks. A CT scan can be quite helpful in knowing what the anatomy is. Next. And lastly, for medical legal purposes, if you are a new consultant and you get a complication and you have not done a pre-op CT scan, it is quite difficult to justify yourself in a court of law. Next. Now, as far as MRI scans are concerned, we don't use them for diagnosis. It's very rare to use an MRI scan unless you've got a very narrow ear canal or patient not allowing examination. You may consider the MRI scan for diagnostic purposes. MRI scan is essentially used for follow-up purposes. So diffusion-weighted non-echoplanar MRI scan in cases of canal wall up, I generally tend to do them at year 1, year 3, and year 5 after a procedure. And it basically helps you exclude recurrence. So be aware that cholesteatoma will appear as a hyperintense signal compared to inflammation or scar tissue or secretions that will be hypointense. Okay. Next. Now, intact canal wall up versus canal wall down. This is again something that comes up quite often. And so there are many factors to consider here. First of all, surgeon training, familiarity and experience. So your exam answer should be, I'm really familiar with both techniques and I will look at other considerations in deciding whether I would want to keep the canal wall up or keep the canal wall down. Next. So patient considerations is quite important. So if you've got a young child, and the disease is not particularly exhaustive, you would want to do a canal wall up procedure if possible. And the reason for doing that is the child is unlikely to allow regular, cleaning up the mastoid cavity in clinic. It is quite restrictive to have a mastoid cavity in terms of activities like swimming. Whereas if you've got somebody who is an elderly person who's got multiple comorbidities, you want to give them the one operation, you give them a mastoid cavity, which can be regularly cleaned up in clinic. Next. So looking at recurrence in residual cholesteatoma, if you have a competent, experienced surgeon who is doing these procedures, there is no real difference in terms of a residual cholesteatoma. However, the chances of recurrence, if you look at the clinical literature, it is higher, slightly higher in canal wall up procedures. Now, this is changing because we now have the use of autoendoscopes to look at sort of hidden areas and look at other sites that were previously quite difficult to see. Next. And again, radiological considerations are important. As I mentioned before, if you've got a very large pneumatized mastoid air cell system, if you end up with a large mastoid cavity, you get mucosa formation rather than squamous tissue formation, which leads to chronic discharge. Next. And as far as hearing aids are concerned, you can use them in both, in canal wall up or canal wall down. However, your options are better in canal wall up. Okay, next. So discharging mastoid cavity, this is again something that comes up commonly in the clinical scenarios. It's very easy to get hold of a patient who's got a mastoid cavity and for you to examine that and then, you know, get questions based on that. So what are the common causes of discharging mastoid cavity? Next. So the first and the most important one is residual and recurrent disease, particularly residual disease in areas like the sinus tympani, the sinodural angle, and the anterior epitympanum. Next, again, having a high facial ridge that forms a sump. And if you've got ledges and troughs in the mastoid cavity, and the mastoid cavity is not smooth, again, you can get chronic discharge. Next. Inadequate meatoplasty is another common reason for having a chronically discharging cavity. You cannot visualize the mastoid cavity or not clean the mastoid cavity because the meatoplasty is small, can lead to chronic discharge. Next, perforated tympanic neotympanum, CSOM, again is you get chronic otitis media, and that itself can cause, you know, the mastoid cavity to discharge or stay wet. Next, mucosalization. So if you have a very large pneumatic cavity, that favors mucosa formation, and that results in chronic discharge. Next. And if you've got a sump at the inferior aspect of the cavity, now the reason for this, the most common reason is there is inadequate removal of bone around the mastoid tip. Okay, next. Now I'm going to move on to retraction pockets. Now it's pretty important, you know, for most topics to have some kind of a definition that you can use as a starting point. Okay, next. So one important sort of, you can use the definition, a textbook's definition, or just make up something on your own. For example, my definition of retraction pocket is merely, you know, invagination of part of the tympanic membrane medially into the middle ear. Now, moving on to classification, there are multiple classifications, and if you are really very well prepared in otology and you are you know, otology viva is going to be your strength, you can mention all the other classifications. You've got Erasmus, you've got Boers, you've got Charakan. The common ones that the examiners are aware of are Sade and Toss. So it's important to at least know what the grades are. I personally find these classifications pretty unhelpful. I rely more on, you know, a detailed description of the retraction pocket, documentation of symptoms, and documentation of hearing. Okay, next. So there are primarily a few questions you want to ask. There are 5 questions really here. First thing is, can you see the fundus of the retraction pocket? Now, the fundus essentially is the floor of the pocket. So if you can see the fundus and the retraction pocket is not gathering keratin and is self-cleansing, there's not a lot to be done. If you cannot see the fundus, you know, the retraction pocket is in the process of or has already converted into cholesteatoma. Next. Next question is the pocket self-cleansing? If the pocket is self-cleansing, you know, you avoid repeated follow-ups. What you do not want is somebody with a small self-cleansing retraction pockets being seen in the clinic every 6 months or every 1 year. If the pocket is self-cleansing, you can simply discharge the patient. That's what I would do in my own clinical practice. Next. The next important question is, what is the relationship of the pocket to the incudostapedial joint? Now, you know, the part of the middle ear that has got the poorest vascularity is the long process of the incus. So if you've got the retraction pocket that is devascularizing the incus or the incudostapedial joint, obviously that is going to cause a hearing loss, in which case, you know, your management changes. Next. So 40 to 50%, okay, important to carefully examine the pocket, because 40 to 50% of past tensor retractions have past flaccidar retractions and vice versa. Okay, next. Again, a question of management comes up very often. Now, the evidence for managing these is pretty poor. So I refer to the 2010 Cochrane review that looked at surgery for retraction pockets. Now, they looked at 71 patients from 2 randomized controlled trials. So the primary outcome of the review was that there is no statistically significant benefit of doing a cartilage tympanoplasty over a wait and watch approach for either disease progression or hearing outcomes. The secondary outcome was there was no additional benefit to inserting a ventilation tubes over cartilage tympanoplasty alone in regards to hearing outcomes. So what does all this mean in practical terms? So if you see a small retraction pocket that is not causing hearing loss, conservative management. If it's self-cleansing, discharge the patient. If it's not self-cleansing, I see them back annually. Okay. Excision of the retraction pocket and cartilage tympanoplasty is usually reserved for those where the retraction pocket is causing a hearing loss because it's causing erosion of the anterior stapedial joint. In children, it's reasonable to try a ventilation tube first. And the reason for that being, as they grow up, their eustachian tube function is likely to improve because of changing anatomy, and they may not require anything more than a simple ventilation tube at that stage. Next. Okay, I'll move on to CP angle lesions. Again, my advice is, start the answer on a very broad front. Do not get caught up in this is T1, this is T2, this is got gadolinium, this is not got gadolinium, unless you're very sure. Okay, so we know that, vestibular schwannomas are iso or hypointense on T1, T2, and with gadolinium, they are hyperintense in T1. So it's important to look at the specific characteristics. So in terms of the intracanalicular portion, in terms of the CP angle component, in terms of specific characteristics, if you can identify them. For example, if there is calcification, if there is a dural tail, if there are cystic areas, and always do not forget to look on the opposite side. You may have a patient, an MRI scan of somebody with NF2 that has got a very small tumor on the other side. Okay, skull-based MDT is really a buzzword. You have got to mention that somehow in your answer. Now, it's important to remember that for the majority of the times you get this MRI scan, you will have medium-sized tumors. So in which case you have to, remember the basics of treatment, wait and watch policy versus stereotactic radiation versus surgery. In terms of tumor growth, 50% of these patients, 50% of CP angle lesions or vestibular schwannomas tend to show growth. Now, this could be slow growth, periods of slow growth and no growth. Okay, a third of these don't grow, and about 10% exhibit negative growth. Okay, important to know how stereotactic radiation works and which is your closest center. For example, in Edinburgh, we've got we provide stereotactic radiations in Edinburgh itself, which is either given as a single fraction or as given as 4 to 6 fractions. Important to also know how stereotactic radiation works, what is the principle, how it causes cell DNA damage and damage to the blood supply of the tumor, and what are the the negatives or the complications of stereotactic surgery. In terms of surgery, please do not mention that there are 3 approaches used: middle fossa, translab, and retrosigmoid, because if you give an answer like this, the examiner will very quickly know that you've not really gone and seen a case, because we do not use, for example, the middle fossa approach at all in the United Kingdom for excising vestibular schwannomas. So there are basically only 2 approaches: translab, which is reserved for patients who have completely lost their hearing and larger tumors, and retrosigmoid for those where there is minimal involvement of the fundus, the tumors are not very large, and the patient has some residual useful hearing. Next. 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 So we've already discussed all this. Next. Okay. For NF2, I think it's important next to remember the criteria for NF2. Okay, that is there in your textbooks. NF2 MDTs. Now you have to know which is your closest NF2 MDT. Now, when I was taking my exam, there used to be 4 centers: Manchester, Guy's London, Cambridge, and Oxford. I'm not sure if this has changed, but you have to know your closest NF2 center. Next. Important to also know, the subtypes, Gardner's, Wishart, the criteria for NF2, the genes responsible, the genetics. That's all there in the textbook, and I'm not really going to go through it. Factors and influence treatment. Again, this is controversial. We know that stereotactic radiation is not a preferred option because of bilateral disease. In terms of surgical management, again, it is controversial whether you should operate on the smaller tumor in terms of preserving hearing, or whether you should operate on the larger side with a view to curing. Of course, you've got to take into consideration other tumors, spinal tumors and other factors as well. Next. Again, see if you can find, a cochlear implant somewhere to be sort of included in your answer. If the cochlear nerve has been preserved, cochlear implant is an option. If you're operating on the second side, an auditory brainstem implant is maybe necessary. Next. And in terms of, next, in terms of drugs, you have to know, the basic ones. Avastin, for example, how it sort of works. It targets blood vessel growth and causes shrinkage of tumors. Tyrosine kinase inhibitors. The majority of these drugs are used where the tumor is growing more than 4 millimeters per year. Next. So that's really everything for me. Happy to take any questions.
That's a great lecture, Iqbal, Syed. I missed you actually last year. Anyway, that's really good. I think I was closely monitoring because I was moving the slides. So really this time I was observing. What a wonderful talk. Great. Very knowledgeable, I think. Good. Please feel free to ask any questions.
Can I ask, what do you do if you have a retraction pocket and it's already eroded the long process of the incus and it's on the stapes head, which usually isn't as vulnerable to erosion?
If it is already, if it's already caused erosion of the incudostapedial joint, where the long process is gone, the patient is going to present with the maximum conductive hearing loss. So what you have to do is take into consideration all the factors. How old is the patient? What does the patient want? Two things to consider here. Is this retraction pocket already going to progress? In which case, it is going to progress to a cholesteatoma, okay? Or whether it's been stable like this for years and years and years. So if it's been stable and it's not progressed very quickly, the options are a hearing aid versus a cartilage tympanoplasty. If this has been pretty progressive, it's only happened in the next few years, it is very likely to progress into a cholesteatoma, in which case surgery would be the preferred option, not the only option, but the preferred option. And again, it's all about patient choice, all about, you know, patient factors, comorbidities. There is no absolute answer to either of the two scenarios that I discussed. So your answer would be, I would have a chat with the patient. I would like to know how quickly this has progressed. Hearing aid is an option. Surgery is an option. I will, you know, discuss the pros and cons of both with the patient. Is that clear?
Yeah, thank you.
Brilliant. Next is Sue. Are you there? That's fine. I have Miles Bannister's talk. Just one moment.
Whilst you're uploading the talk, Jay, I'm happy to take any more questions if anybody has any queries about anything I've said.
Brilliant. Yep.
Iqbal.
Yep.
With it's Victoria here. With consideration of bilateral stereotactic radiotherapy for NF2, is that not performed because of the radiation dose that they would
That's
have?
correct. That's correct. I mean, it's not that stereotactic radiation is not used on NF2 tumors, but because of bilateral disease, it is difficult. It is tricky. So if the tumors are growing, if both the tumors are growing pretty quickly, then, you know, Avastin or a tyrosine kinase inhibitor is the preferred option. If there's only one tumor that is growing quickly, okay, you can use radiation on that side.
Great, thanks.
No worries.
Brilliant. So Sue, as I said earlier, is a rhinology consultant from Glasgow. He's also a course co-convener who designed all these core materials and everything, who helps me all the time since we started this course. Nearly it's a 12th course. So over to you. Thank you.
Thanks, Jay. Thanks for the kind introduction. I hope everybody can hear me.
Yeah.
Yeah. So can you see the PowerPoint?
Yep.
Okay, great. Okay, thank you, Jay. Thank you for the years of dedication, I have to say. Without you, there would be no course. And I'd like to also thank Kaylee Kennedy and also Linda Fullerton behind us, you know, what we don't see. And also the faculty really for coming and supporting the course. Without you guys, there will be no course, and obviously the trainees. Now, I've been asked obviously to do a top tip kind of talk on cutaneous malignancy, facial flaps and reconstruction. So what will you get asked at your FRCS exam? There's only like two scenarios you get asked. Okay, one probably will be at your rhinology facial plastic station, whereby you get a lesion shown to you on a photograph, either on the tip of the nose or the nasal alar or the nasal side walls or on the dorsum of the nose, or anywhere in the face or scalp region. Usually will be the nose, okay, because there's a lot more discussion you can have with that. Or secondly, you could get asked at your head and neck station, whereby you could perhaps have a lesion in front of the ear, which could be obviously either a SCC or a BCC or some sort of lymph node there. And essentially that you will be asked, what will you do with those cases? So how would you tackle this kind of questions really? And what I like to hear from my trainees is that they have a flight plan. And really when they see a patient, they should be thinking of three things really: the tumor factor, the proposed treatment, and the patient factor. And these are really the top tip really. Tumor factor really is the indication for surgery. Okay, what are the differential diagnoses in this case? Sometimes it can be just one thing and you will say it with conviction. And then sometimes it can be more than one thing, okay? And especially if the the examiner said, what else can this be? Make sure you try to think what else could it be, okay? Have a few options there. Proposed treatment will be, what will you propose? And that will be including the non-surgical treatment. So the medical treatment that the dermatologist tends to use, and basically know a little bit about it and whether is this effective. Excision margins, because we're all surgeons, we're going to plan to cut this out, and we need to know the excision margins, and you use your guidelines from BAD or the JLO head and neck paper, position paper, and then use that as your guide. The size and site of the defect, obviously, you need to talk about that. And then what's missing in terms of component, whether it's just skin, subcutaneous tissue, muscle, or there's bone missing as well. So when to reconstruct, there's often a debate whether these days, we're probably moving towards more, considering delayed reconstruction until we get our margins cleared. We won't proceed with reconstruction, or you can put a full thickness skin graft or some sort of primary closure if you need, and delay that. If there's a big defect, you would just dress it and cover it and then wait for the histology to come back. That's not a bad option. In fact, these days, perhaps it could be a preferred option for larger tumors. So options for reconstruction, use your reconstruction leather. And then these days, we talk a lot about more micrographic surgery. It used to be something that very few centers have this, but then these days, there's a lot more centers have it now. So you need to know a bit more micrographic surgery. When it comes to patient factor, obviously, we all have to remember that patients these days are not the fittest, and we have to, account for that when planning surgery. And also patient's choice. What does the patient wish to have? And you have to be able to discuss all this with your patient. And your patient may not want to have a lot of scars on their face, even given that they are maybe 80 or 70 years of age. They might be very conscious about that. Now, these are usually what you will start off with, really. They will give you a picture, really, and you will like to, what you need to do is describe the lesion, where it is, okay? And in terms of the site, the size, the color, the margins, and what are the surrounding skin looks like, and the potential differential diagnosis that you think it could be. So BCC obviously being the most common skin cancer that we see, and it is something that will come, as one of your exam questions. You come across that quite regularly. And it's obviously related to sun exposure, like all skin malignancy. It can be associated with the PTCH and P53 gene mutation. And also remember that if the patient's quite young, although it's very rare, and they have multiple lesions, it could be obviously Gorlin syndrome. And know a little bit about Gorlin syndrome. They tend to obviously have multiple lesions. There are certain features. They will have broad forehead, palmar PAEDS, keratocystic odontogenic tumors, so they might have some sort of dental history that you'll be interested to look at, that sort of thing. So relevant clinical history and examination to support diagnosis. Often you get asked, and obviously you need to, they'll say, how would you manage this patient? And obviously you will take a focus history, and in your focus history, what will that cover really? You want to know about age, occupation, sun exposure, how long the lesion's been there. So specific to the lesion itself, whether things have changed, and history of skin malignancies. And then when it comes to obviously doing your examinations, you obviously have to talk about skin type. Okay, use the Fitzpatrick skin type 1 and 2, obviously render someone more likely to get skin malignancy, whereas you're 5 and 6, then you're less likely perhaps to develop skin malignancy. There are also other sun exposed areas. Don't forget about that, to examine that, that could be in your arm or lower limb, and then neck as well. So you need to obviously know about high risk and low risk BCC. High risk, obviously, high risk features for BCC for recurrence are tumors which are larger than 2 centimeters. That's often referred as large tumors, that you'll come across that in many papers that will say that. And then site where it is, center of the face, but also the ear can be high risk, okay? Poorly defined clinical margins, high risk histological subtypes like the morphic, the infiltrative, the micronodular, the basal squamous. Those are high risk clinical histological subtypes. if there's perineural perivascular involvement, obviously that's a high risk feature. If this was a recurrent tumor, you would treat it differently. And if the patient was immunosuppressed or they have Gollan syndrome, those are also high risk, okay? In terms of obviously management options, what are the options? This is a very old table now, but obviously BAT has not updated their BCC guidelines for quite some time, and they're still doing the update at the moment. And the thing is, obviously, what this doesn't contain is obviously 5-FU, which is quite similar to topical imiquimod kind of efficacy. Now, if you looked across the table, obviously you have something which is non-surgical on the left, and then if you move across, you have your surgical treatment, which is obviously excision and more micrographic surgery. Now, the thing is, the take-home message is that if the lesions were superficial, small and low risk, then obviously you could obviously use the non-surgical treatments, and when they become larger, higher risk, infiltrative, and you will be thinking along the lines of actually excising this, or perhaps refer them on to more micrographic surgery. Now, AirwayVeg is something that's basically you should know a little bit about it if you get asked, okay? And it is obviously a good evidence to show that it's effective in patients, you know, with recurrent tumors, okay, or not suitable for surgery. And sometimes it can be used post-radiotherapy, and this is one of the treatment options. In terms of the surgical excision and margins, you need to obviously know this really very well, because you'll be asked, okay, when it comes to excising things, you need to know how much of the margin you take. Something low risk, you less than 2 centimeters, I said 2 centimeters and beyond, it is what we call big tumors, okay? Something low risk, okay, and less than 2 centimeters, you would take a 4 to 5 millimeter margin. And by doing that, you get the 95% clearance, okay? And if there are certain, however, saying that there are certain areas which are what we call aesthetically sensitive areas, particularly like the nose, sometimes the ear, you know, it is impossible to take a huge chunk away. And the thing is, when it's not possible to take a huge chunk away, you're left with a 2 to 3 millimeter kind of margin. And those patients, you may obviously will consider perhaps a delay reconstruction if you're concerned, you know, pop a little bit of a skin graft if that's appropriate, or dressed it and then come back another day, you know, to reconstruct this. Or you may obviously have to observe this patient's long term. Now, when it comes to bigger, larger tumors and the more infiltrative, the more vague, the higher risk tumors, obviously we're talking about the bigger, the better, really. And the reason is obviously is to do with clearance, okay? So if you take something like a 3 millimeter margin, you may get a clearance of 66%. And a 5 millimeter, you get 82%, okay? And if you take more than a centimeter, you're looking at obviously a clearance nearly more than 95%. Now, recurrent risk is something sometimes people like to ask, okay, oh my goodness, this histology has come back and the margins are positive, okay? It can be positive on the deep margin, can be positive on the peripheral margin, wherever it is, okay? What's the likely risk of recurrence? And you need to know, okay, peripheral margins is not as bad. Obviously, deep margins have a higher recurrence, and you really should, obviously, if there's any positive margins, either way, you should go back and cut some more. Now, obviously, when it comes to recurrent BCC, you will be looking at taking bigger chunk away. And that's the reason for that is obviously that this is a recurrent tumor. So like we sort of said before, higher risk tumors, you can obviously consider delayed reconstruction or more micrographic surgery. Now, moving on, obviously, what are the reconstruction options? Okay, use your reconstruction ladder. Obviously, start from very simple to more complex. Okay, secondary wound healing these days, I don't think it's obviously possible that as an option, but it's not something that perhaps the examiner would like to hear. They're probably looking for more like flaps and, you know, regional flaps, local flaps, that sort of thing. So when you state a preferred choice, okay, so obviously you have a preferred choice and you must justify your choice, know about how to do it as well, the technique of doing it, and obviously the reasoning for using that choice, okay, for using that flap perhaps. And they may want to know sometimes other options, okay, if it's a choice that perhaps is not so these days they have standardized questions and answers, okay. They're like keywords essentially. And the thing is, it may not be the choice that they have in mind. So basically go through another choice, okay? So obviously be prepared that you have more than one option. Now, when it comes to talking about reconstruction, you need to know about facial-static subunits and nasal subunits. There are 9 of them, okay? And if more than 50% of the nasal subunits you have a defect more than 50%, then you need to replace that entire subunit. I also know a little bit of RSTL as well, okay? This sort of things are given, okay? Now, flaps is what you often get tested on, really. Knowledge on flaps. You have obviously your axial flaps or your random flaps. Now, this is based on blood supply to the flap, okay? There's also, you can categorize flaps into how the flaps moved, okay? In terms of axial flaps, okay, they have a name artery supplying the flap, okay, there are only a number of them. The surviving length is obviously relates to the length of the included artery, is usually 2-staged, okay, you have sometimes more than 2-staged, okay, if you want to do a little bit of refining work, you might need more than 2-staged. And the second stage is usually about 4 to 6 weeks, really, because you want the second stage is to obviously to divide the pedicle. And then you obviously would like to do a bit of touching up or refining work. So examples of this kind of flaps are the paramedian forehead flap, okay, the nasolabial flap, the Abbey Eslander flap, which is good for the corner of the lip reconstruction, the nasolabial flap, obviously for anywhere then kind of nasal alar or the columella region, sometimes a little buccal kind of defect, you can obviously use that. The paramedian forehead flaps, very good for the lower half of the nose, okay? And you need to know the blood supply to those flaps, okay? So those are those blood supply. Then random flaps, the rest of the other flaps, most of them are random flaps, okay? So they are based on reached subdermal vascular plexus, okay? The length to the width ratio has to be 3 to 1, roughly in the face, okay? And examples of this are obviously your advancement flap, the rhomboids, and the bilobe. Now, this is an example, obviously, of a random, more of a random flap. Okay, they are not nasal dorsal advancement flap, which is something that you could use for a nasal tip lesion. Okay, so when you have a lesion such as these, okay, on the tip of the nose, obviously you have to mark out the lesion. You will mark out the margin of the lesion. Okay, whatever it is, 4 to 5 millimeters, looks like perhaps a nodular cystic BCC, but in a high risk area in the center of the face. Okay, and essentially you would take that away, and if you take that away, how would you reconstruct that? And I liked this nasal dorsal advancement flap, which is what also known as the Rhinology flap, because it heals really well. Okay, and you can see the whole nasal subunits has been shifted down, and it really hides the scar very well, so the patients don't really see it. It might look terrible at the start, but then it does finish quite nicely after that. Now, there is obviously other kind of advancement flap. Okay, advancement flaps are just flaps that slides in one direction, okay, into the defect. Okay, you will end up with a bit of excess skin around the corners, and we will do what we call Barrett's triangle and just cut that away, which is not a big deal. And it's usually good for the forehead or the brow area. So examples of this are obviously the H flap on the forehead, which is great to use, and obviously the V to Y advancement flap, which is really good for the nasal alar kind of defect, smaller defects, not the huge full thickness one. Now, bilobe flaps are one of those favorite questions that the examiners liked, okay? And it is obviously is what we call a double transpositional flap or interpositional flap. They're quite the same thing. Okay, literally you have a defect and then you have to create 2 flaps to close it, essentially. So the blood supply is obviously random blood supply from the musculocutaneous and cutaneous arteries and perforated subcutaneous tissue vessels. Okay, they're good particularly for nasal dorsum, okay, nasal tip, temporal region. I don't really like it very much, but it does obviously cross different subunits when you have to rotate 2 flaps, and you get a more visible scar. Okay, but on the nasal dorsum, it just depends how you angle it, and you can get quite a good kind of cosmetic outcome. Now you need to know how to draw them. Okay, so the thing is, in the olden days, they used to provide pencil and paper on the table and then ask you to draw them. Now, these days, I'm not quite sure whether you still actually been provided that, you know, given obviously it's COVID, okay, but you need to know how to design that flap, okay. You know, so basically, if you look on the right, okay, you have obviously a pivoted point, okay, like Mr. said, you would have a lesion with a defect, okay, and the diameter of the lesion, the next one is either the same D or 3/4 of the D, and then the following one will be a lot smaller, that will be a half a D or to a 3/4 of the D. Okay, and the thing is, they have to rotate about 45 degrees, okay? So for the nasal dorsum, it can be a bit larger, basically, so that you get a better cosmetic outcome. Now, obviously, there's always other options, okay? Aside from putting flaps, obviously, you can start with really simple things like skin graft, okay? It's never a bad idea sometimes to consider skin graft. Now we use mostly full thickness skin graft rather than split thickness skin graft. You probably use that for more of the kind of head and neck kind of reconstruction. If you need to pop a little bit extra skin somewhere that your pec major flap wasn't able to cover that, you might use a split thickness skin graft, but we also use split thickness skin graft to cover paramedian forehead, kind of the donor site. Okay, if there was a bit of obviously the donor site, you can't close primarily, you've got a bit of defect, you may want to pop a little bit of the split thickness skin graft just to cover what's remaining. The full thickness skin graft obviously it's pretty good for nasal tip, okay, and kind of conchal area essentially, but it's not something I like very much. There's a color match issue sometimes with it, okay, and they tend to contract a bit. You know, they look as if they were dying off a little bit, but then, you know, you just have to persevere with it and cream it continuously, and it will obviously heal. But you will get a little bit of contracture sometimes, and it can scar quite badly on some patients, but saying all that, it does heal quite nicely on some patients too. Now, for larger defects is our everybody will know this, is the paramedian forehead flaps. Okay, when we talk about large defect, this is the interpolated flap. Okay, so it's got a name. So it's also an axial flap, but it's interpolated, whereby it crosses a intervening tissue. Okay, you use it for big defects, lower half of the nose, if you have to do a partial or a rhinectomy and you will like to have this covered, what will you use? A paramedian forehead flap. Okay, defects 2 to 3 centimeter, and essentially it's a 2-stage procedure. Okay, you need to know the blood supply. Essentially, it's the supratrochlear artery, and where's the supratrochlear artery is about 3 millimeters from the medial canthus, 2 centimeters from the midline. Okay, how would you locate this? Okay, this is some sort of guide. You will locate how you locate it. You can obviously also confirm it with a Doppler. Okay, when you're actually planning this in theater, you use obviously a Doppler machine, mark them out, okay, essentially where this artery is, and then, you know, how far is from the midline. And obviously you have to mark out the pedicle as well. You need to know how big of a pedicle base you need. It's about 1.2 to 1.5 centimeter. And the reason for that is obviously you don't want to compromise the vessel as you rotate it from top to bottom. So moving on, okay. Now, there are other flaps, obviously, you should know, which is obviously the nasolabial flap, which is one of those questions they will ask, particularly good for alar reconstruction or columella reconstruction, or like research said before, if you have a small defect in the oral cavity, you may want to, you can use this to reconstruct it. Now, the thing here is it is also an interpolated flap. Okay, it's only an axial flap if it's inferiorly based. Okay, when it's superiorly based, there's a debate whether this is still considered axial flap. Is more of a random flap actually, because obviously, as you know, the angular artery, which is the main blood supply to the flap, comes inferiorly. Okay, so is the angular artery. It is obviously a branch of your facial artery. Now, nasal dorsal glabellar flap, okay, something very good to reconstruct nasal side walls, okay. They heal beautifully, okay. Patients don't really see a huge scar, although they look terrible at the start, but then they often heal very well. And there's obviously a named blood supply to this flap as well, which is the dorsal nasal artery, which you need to know. And then, like research said, it is suitable for defects less than 2 centimeters roughly. Now, full thickness alar defect is something that will come up, perhaps will come out in your exam. Okay, so you will have a lesion perhaps on the side of the nose. Okay, and it could be either a BCC or SCC, and you would perhaps consider a punch biopsy if you or incision biopsy. Okay, if you're not sure whether you like to take this as a primary excision, okay, because it's an aesthetically sensitive area. Okay, and if it once you've done that and then you end up with perhaps they say to you, okay, this is a infiltrative BCC, you will have to take quite a massive chunk away, and you end up with a sizable defect. And sometimes it can be a full thickness, and sometimes it's just a partial thickness. Okay, if you have a full thickness, okay, you need to know how to reconstruct this. Okay, and this is just a guide really. If you have a defect like less than 1.5 centimeters, so that means that 1.5 centimeter that also covers the alar rim. The alar rim has been removed. Okay, and it's 1.5 centimeter. Okay, vertical height. Okay, what will you use? Okay, now obviously that itself, you'll need a bit of cartilage. Usually you harvest cartilage from the contralateral ear, essentially. Okay, so right side, left side kind of thing. So right side defect, left side ear, okay? And you will use a bipedical vestibular skin advancement flap, okay, V2Y, or you can obviously use our favorite nasolabial flap, okay? And that will be obviously a 2-stage. Either way, you should obviously have a 2-stage operation because you do have to refine this. They do contract, unfortunately. Now, when you have a defect which is greater than 1.5 centimeter in its vertical height, okay, you will obviously need 3 layers now. Okay, so it's no longer just the nasal vestibule is gone. Obviously, you can use that skin, you flip it into the nose, and you will obviously try to recreate that alar rim with the cartilage. Okay, but you also have that mucosal defect, and with a mucosal defect, you really need to take a mucoperichondrial flap. Okay, usually is anteriorly based hinge flap, okay, which you turn around, and obviously that nostril is going to be quite occluded by all that. You can obviously put a little temporary stand like a nasopharyngeal airway, okay, and you can obviously modify that and then stick it in and suture it in, and then when you do your second staged, you basically will take that out and reconstruct the whole thing, cut the pedicle away. Now, how will you ensure clear margins? People like to ask that. Obviously, you can take a frozen section. These days, frozen sections are very difficult to organize, very time consuming, and probably with COVID times quite unheard of now. Quite difficult to do for a skin cancer. Then obviously more micrographic surgery really, okay, is always an answer for any of those difficult cases. Need to know a bit of more micrographic surgery because you would like to know, oh, tell me a little bit about more micrographic surgery since you say that. Okay, obviously what's the technique used for to gain total histological control. How's it excised at the standard margin at 45-degree angle? Then the sample squashed, and horizontally sectioned instead of vertically sectioned. Then they're mapped out, okay, using color-coded sections, usually in 4 quadrants, okay. And then they are examined based on the tumor map, okay, whichever tumor, whichever quadrant is involved, obviously they go back and excise some more. The cure is obviously very good, more than 99%, and obviously for recurrent lesion is more than 95%. Now, those are figures that you need to know and be able to quote, okay? Now, obviously, it can be shown perhaps a lesion that's not BCC, okay? And what's next will be squamous cell carcinoma, okay? They tend to be a bit more nasty looking, bigger sometimes, and not necessarily true for every case, okay? You can obviously get SCC in the nose as well. And what you do, describe the lesion and the location, okay? Incision biopsy, if like you sort of say, aesthetically sensitive area, large tumors, not so sure, incision biopsy or a punch biopsy is often the or core biopsy is often a good idea rather than punch biopsy. Sorry. So this sort of cases you might want to do imaging, but not for so much the nose, depending where it is in the nose, okay? But for on the side of the face, obviously in the parotid region, you will like to image after obviously you take a biopsy in clinic. So choice of imaging, you can have your CT, MRI, or do both, really. And then in the parotid region, you will obviously check for facial nerve functions, okay? You want to see whether is this tethered to the parotid lesion, parotid, gland underneath, whether there's any nodal involvement as well. Now, the guidelines for primary cutaneous SCC, this is just been updated really in March by PAEDS, okay, March this year. So it's worth looking at that paper. We will have a bit of, there's a few slides from that paper, which we will go through. Okay, now this is not from PAEDS, but this is from the head and neck position paper, which is, published in 2016. And you need to know about high-risk features of cutaneous SCC and what they are, okay? Because obviously there's a prognostic factor, and there's also it will be something that will affect your decision and how you proceed with this sort of cases. So size, again, as we sort of say, anything large is considered as 2 centimeters and beyond, okay? Because they're more likely to recur and they're more likely to metastasize. Site-wise, they're not so dissimilar from BCC anywhere in the center of the face, the year, and then there are other things like radiation or thermal injury, history of thermal injury in that place, okay? More likely to obviously have, they're considered high-risk area, Bowen's disease. Okay, failure of previous treatment, if patient's immunosuppressed, okay, the depth of invasion is important. Obviously, there's anything more than 2 millimeters thick, okay, is high risk. Anything less is lower risk. Clark's level, which we use less of these days. Perineural, perivascular invasion. And obviously, the histology, if it's poorly differentiated or undifferentiated, will be high risk. Then this is the TNM 8 edition, which is the latest edition, really, and really know about what's T1 and what's T2, 3, and 4. Anything less than 2 centimeters, T1, 2 to 4 will be obviously 2, and T3 is more than 4. T4A will be if the cortical bone or the marrow is involved, okay? T3, you can have a bit of bone erosion, okay? And a bit of specified perineural invasion, but in very small amounts, okay? Anything else beyond that will be a T4, okay? But if you have gross cortical bone or marrow invasion, then it will be the T4A. Then obviously if it's something that's involved the skull or the epidural space, it will obviously be a T4B. And obviously, this is just the end staging. Essentially, is not that dissimilar from head and neck kind of end nodal staging. Okay, and then obviously so as the end staging. Now, this is obviously from the the PAEDS guidelines, which is published, just been updated in March. Okay, some of you might have seen it, but if you have not, it's worth having a good look at it. Okay, and we're talking about primary cutaneous SCC. Okay, we're not talking about SCC anything else. Okay, and the thing is, they just divide them into freely mobile tumors or clinically fixed tumors. Okay, now if you look at freely mobile tumors, then you'll offer the standard excision. Okay, next to the next anatomic deep plane. Okay, so if the diameter of that lesion is 2 centimeters and below with no risk factors, okay, then you would take at least a 4 millimeter margin. If the diameter is less than 2 centimeters, but it has at least 1 risk factors, or more than 2 centimeters, but no risk factors, you take a 6 millimeter margin. Okay. If the diameter was larger than 2 centimeters, more than 1 risk factors, or the diameter is more than 4 centimeters, okay, you would take a 1 centimeter margin. Okay, so the bigger the tumor with more risk factors, the bigger margins you would take. But the smallest margin you would take is a 4 millimeter margin. Okay, now then obviously what you do about repairing, you can obviously just do a linear primary closure, okay, if you're not sure, or you can graft it with a bit of full thickness skin graft, or you can just dress it and then wait for histology to come back. Now, if you have a positive margin, okay, or less than a millimeter clearance, okay, you will go back and cut some more. But if you have a clear margin of more than 1 millimeter, peripheral and deep, and no other indication, to no other risk factors that you'll be worried about, then obviously is just observe them, you follow them up. Okay, now obviously in this kind of situation, more micrographic can be considered where it's applicable and where it's available. Curettage and cautery is not something we really would do and advise, and often these are things that's for smaller lesions, lower risks or no risk factors, that sort of thing. And radiotherapy is an option for a non-surgical candidate. When you have obviously something which is fixed, or you have a bone involvement, okay, on imaging, then basically you obviously will consider offering surgery, okay, but you will take a bigger chunk of margin, and you may have to resect the bone as well because of it might be involved. And then those patients will probably, very likely, will have to have post-op radiotherapy treatment. Now, just to recap really, okay, so excision margins, okay, it's small tumors, low risk, 4 millimeters or greater. High risk, you're looking at least a 6 millimeter, more so to a centimeter kind of margin. Okay, more micrographic surgery is often a good option, okay, where if you have this available, okay, and this sort of cases need to be discussed at the skin MDT, okay, and then delay reconstruction is often advisable. Now, Parotid, okay, and nodal disease, okay, this is from the GLO head neck position paper, really. Know a little bit about it. Okay, what do you do with if the parotid was involved, or if the nodes were involved, and both parotid and nodal disease is present. Okay, so the thing is, you obviously, well, if the parotid involved, you resect the parotid lesion, the parotid tissue, and then you would do perhaps consider a neck dissection. Okay, if the parotid is not involved, the nodes involved, basically you need to know whether the anterior nodes are involved or the posterior nodes involved, and then you would do as it says there. Okay, high risk primary tumors, okay, sites are, you know, if they're in the temple, forehead, and scalp areas, they're quite high risk to spread. Now, reconstruction options, basically bigger the tumor is on the side of the face, then obviously you can use a submental island flap. This is really quite a nice flap, not too difficult to do, and really heals very well because it does have a blood supply to it, which is branch of your facial artery. Okay, and it really hides the scar very well, match the skin really well too. And it also can be used for oral defect too. Now, other things obviously is that you cannot, if it's just skin itself that you need to cut away, you can obviously do a cervical facial advancement flap, but usually you will be expecting to take a deeper resection, do a deeper resection, and hence you will obviously need either a submental flap, or you can obviously use a pec major flap, which most of you might know from head and neck, really. And if you are going to mention about pec major flaps, they would expect you to know things like blood supply, which branch of the artery supplies it, okay? How do you design the flap? Okay, what's the surface marking, that sort of thing, and how far can the flap reach, okay, up to the zygoma. Follow-up, okay, how would you follow up your patient? Okay, low risk, okay, this is from the bad paper again. Low risk, okay, 1 appointment for diagnosis and education post-op, and that's it. Okay, high risk every 4 months for 1 year, then every 6 months in the second year. Very high risk, okay, so they do obviously in that paper, they put down what's low risk, what's high risk, and very high risk, okay. You will do every 4 months for the first and second year, then every 6 months for the third year, and metastatic cutaneous ones, obviously 3 monthly interval for 24 months, not 24 years, sorry, then 6 monthly for 36 months, and with the potential view of long-term review. Now, melanomas, cutaneous melanomas is something that the trainees often like to know a little bit about, and often this is something perhaps less likely to be asked. Okay, you may be asked, but but it's not something comes up that often, okay, but need to know a little bit about it. There is the nice guidelines, okay. How would you assess the sort of patients? Dermoscopy, genetic testing, okay, you need to know how to talk about genetic testing towards, obviously, because the reason for that is because they're targeted therapy to BRAF and the MEK inhibitor. And the thing is, obviously, vitamin D, big these days, not just for COVID, but the sort of vitamin D levels tend to be suboptimal in patients with skin malignancy, such as melanoma. And obviously, that there are studies which shows that the higher levels of vitamin D, they do better, okay? And that's related to mortality, less mortality. Now, or lower mortality. Now, the thing is, there is also the AJCC classification, and basically you need to obviously stage your patient, okay? So it starts off with something, they use obviously the breast load depth, okay, the thickness of the tumor, okay? And for anything T1 is less than 1 millimeter, okay? If they have ulceration, that will bring you from T1A to T1B, and it will be the same for the other T stage as well. So in terms of obviously excision margins, okay, how big of a margin will you take? Okay, a stage 0 melanoma, which is something perhaps we don't see a lot, okay, and this is something that perhaps the dermatologist will see. You take obviously a 0.5 centimeter. The stage 1 and 2 ones are something that we probably will come across more. You'll have to obviously take a 1 to 2 centimeter. Okay, the bigger the tumor, the bigger the margins will be. Topical imiquimod is something that we tend not to give out as well, but the dermatologist would, and they're only suitable obviously for smaller tumors and what we know as the stage 0 melanomas, and usually used only if excision wasn't possible. Sentinel lymph node biopsy, okay, any point doing those things for melanoma? Obviously there is trials that looked at them, okay, then why is it important? It's for lymphatic mapping and it's with lymphoscintigraphy. So positive sentinel lymph nodes can upstage a patient, okay? So obviously that will affect treatment. Now there are 2 international multi-center RCTs, okay, that's, you might be interested to look at those things, okay? And essentially is to evaluate the role of completion lymph node dissection after positive sentinel lymph node biopsy, okay? These are big trials, okay, and everyone knows about them, okay? They're the DCOG SLT, okay, and the multi-center selective lymphadenectomy trial, which is MSLT2. Now there's a 1 and 2, obviously. Now there is, for the DCOG SLT, there's no difference in distant metastasis for free survival, recurrence-free survival, and overall survival, okay? So one's pretty much against it. And then obviously for the other trial basically shows that completion lymph node dissection does increase rate of regional disease control, but did not increase the melanoma specific survival at 3 years. Then there's obviously the adjuvant and the neoadjuvant immunotherapy, okay, which is big on melanoma. Okay, two main groups. Okay, one that obviously targets the immune checkpoint that inhibits it. Okay, and the other one is obviously inhibits the BRAF and the MEK receptors. And the thing is that there are obviously studies, okay, trials again, clinical trials, lots of them, the 4 big ones, okay, that's if you're interested, you should look at them. But what the trial shows is basically the patients do better. Obviously, they're alive and they're relapse free at 18 months and 36 months, okay, compared to placebo. Now, radiotherapy, okay, adjuvant radiotherapy. So this is recommended, as we have said, for head and neck melanomas, okay, big lymph nodes, okay, 3 centimeter and beyond, okay, patients who have multiple lymph nodes or they have extranodal extensions. Basically, they show that if you give them adjuvant radiation, there is obviously improvement in the local regional control. However, there is no improvement in overall survival or recurrence-free survival compared to the observation after lymphadenectomy. Now, the conclusion for all this is basically use the guidelines on managing skin malignancy, know your excision margins. The repair often is dependent on the complexity of the wound, okay? Use your reconstruction ladder. And my top tip will be this, really, is when you see a patient or get asked about a question relating to any facial plastic is, what's the tumor factor? Have a proposed treatment planned, and always have to think about the patient factor, really, because that should be part of your treatment plan. Any questions?
Perfect, sir. Loads of information. Thank you. That's very useful. I will try and send the recorded things securely to the delegates at some point. It will be very useful. Thank you. So we are running like kind of 15 minutes late. That's not because of Sue, it's a cumulative delay. Credit goes to all the previous speakers, including myself. So we'll have a 15 minutes break. The mild stock is recorded, that's a good thing. So we will start with I think Sunil is going to do, his talk is always wonderful. I don't know whether he's there, but we will start with his talk at maybe 10 past 11. Will that be okay?
Could I just ask a question about the last talk?
Please, yeah.
The thing I always get confused about is how to confirm histology and then plan your margins, for example, on the tip of the nose. So, what kind of biopsy do you go for?
So you can obviously take, you know, how you have a core biopsy or a punch biopsy. Okay, they come in 2 millimeter or 3 millimeter. Okay, so you can obviously use that, take a bit of the normal area and the lump itself. Okay, so don't punch the whole lesion essentially. So which means you take a bit of normal skin, you're taking the you're doing the punch biopsy on the edge of the tumor essentially. So you have to include the tumor and the normal skin. And the thing is, because you don't want to take, sometimes the lesion itself can be really quite small. Okay, that's obviously debatable. Whether would you consider a punch biopsy, particularly on the tip, okay, or you just go ahead and do your excisions, okay? If it's a larger lesion, then obviously, and it doesn't look just like a simple BCC, like a nodular cystic, for example, then you're a bit concerned that this looks potentially could be an invasive BCC or it could be SCC. then you would take a punch biopsy on the edge of the tumor. So you will include the disease part and the normal part.
Are there occasions when you can't do that and you do an excisional biopsy?
You can,
and if
obviously.
you do you take any margin, or do you just, what margin do you go for if you end up taking an excisional without knowing the histology?
So if it was, let's say, a nodular cystic, okay, so one typical appearance of a pearly raised lesion, maybe a little ulcer in the middle, maybe no ulcer in the middle, but you think, okay, nodular cystic. Likewise, it could be just a simple nevus, you know, non-pigmented one. And the thing is, I would take at least a 3 mm margin. On the nose is very difficult. We can't actually take a 5 mm margin. As we sort of said, try to aim for a 3 mm margin. Now, obviously, you have to remember, obviously, is try to avoid the soft triangle. Don't cut into the soft triangle because it scars terribly. And unless you know that this is going to require that excision, I would try to make sure that I don't cut into it. Okay, the soft triangle of the nose. Okay, those are areas that you shouldn't touch, or else it would just pinch terribly. So you aim for a 3 mm margin if it's small enough. Okay, and in view of, obviously, you can't reconstruct with just a full thickness skin graft, a Wolf's graft that you just take from the back of the ear and then pop it on and come back another day if you know, or come back another day, you know, if you feel that I'm not comfortable to reconstruct this. Okay. Likewise, if it's a BC, not just cystic BCC, I do just reconstruct it with a flap. I don't like a full thickness skin graft that much, but I still do use it. Does that answer the question?
Yeah. Thank you.
Any other questions? No? Everybody's happy enough?
Can I ask a question, please?
Yes, of course, Mohammed.
Yeah, so can we differentiate clinically between a primary squamous cell carcinoma invading the parotid or primary parotid tumor infiltrating the skin?
Most often the skin invades the parotid rather than the parotid invades the skin. Okay, so but obviously, when things are not clear, in this kind of situation, you will never just excise it, okay? Either way, you would take a biopsy, you would image them, you would discuss it, you're at your MDT, your head and neck MDT, not just the skin MDT. You know, these sort of things are most often discussed at the head and neck MDT. And, you know, the view is that you would just treat them the same way, really, you know, whether this is skin or this is a parotid, you know, obviously a parotid SCC.
All right. Okay. Thanks so much.
One question, please. When you make a for delayed reconstruction, are you waiting for the histology or are you waiting for the wound to contract?
No, you're waiting for the histology. So the thing is, obviously, as we sort of said, you wouldn't do frozen sections. You know, more micrographic surgery is obviously ideal. Okay, it can be an answer for everything really if you get asked. Okay, when it comes to any head and neck or cutaneous malignancy. Okay, Mohs top. Okay, these days they're very available. If you have that available, you can obviously mention it. But what the delayed reconstruction means is that you will wait for the histology to come back so that you know that your excision is complete, the margins are clear. Okay. So as we sort of say, certain margins are not possible to get that 4 mm, you know, then what we expect, a 1 mm is sometimes enough. Okay, it's fine. And then you will reconstruct. Any other questions? No? Okay, so we're going to break for coffee break now, and then we'll see you back.
So how are you?
I'm good. I was coughing terribly and I was like, honey water, where's my honey water? And my voice is going. But yeah, how are things?
Good. Things are good. Things are good. Are you doing it from home or from hospital?
Yeah, I thought it was yesterday and I had all set up at work because there was nobody at work. And we've got like big computers, you know, to teach the medical students. But
I see.
The thing is, what happens is that obviously I can't use those rooms because there's clinic running today. So I'm just doing it from home now.
It works well. Hi, Aaron. Are you there? You might have gone for coffee, I think. Yeah. David is here.
So how are you, Jay? Are you keeping well and family all well?
Keeping very well. No complaints. No
Oh,
complaints.
no complaints. You always have no complaints. That's that positive attitude, you know, we just have to soak it up from you, you know, positive attitude.
Yeah.
So, yeah, so it's been, oh, that's David.
David, yeah, David, yeah, is here.
Okay. Oh.
Good. David, are you happy to share screen? You're comfortable, isn't it?
Yes.
Yeah, can check it.
Do you want me to check it now?
Yeah, why
if
not?
you're comfortable, that's fine, because Iqbal struggled, then I have to present on behalf of him. Sorry, moving the slides. Yeah.
Okay, I'll just get up the presentation. So is my talk still at 11:50 or?
Yeah. No, yours is after Sunil Sharma from Liverpool. I think he said he will join at 11:15. That's what he said. Yeah, but I'm going to play Miles' video before that as well. We have a time because we have 10 minutes in the end. There's a sponsors video. I'm not playing any sponsors video. We don't have any sponsors for this one. So we have time. So 15 minutes we have time at the end.
So yeah, sharing my screen.
That looks fine. Brilliant. Yeah.
This thing they have to all learn. Okay, so I've got 20 minutes. I'll try and aim for 15 minutes and 5 minutes questions.
Yeah, no worries. Yeah, okay. You can take a little bit. As I said, there's no sponsors video. We can.
Has Miles Bannister given his talk already, or?
No, that I'm going to play. That's what I'm 11:10. We will catch up. Should be
all right. Okay.
I can control because it's recorded.
Okay.
Good. Excellent. So did you attend the Scottish Head and Neck Conference? Was it?
What?
Did you attend the emergencies in head and neck, the conference which we did last month?
I think I kind of joined at the end, basically. I didn't attend the whole thing.
The whole thing, okay. The recordings are available. If you want, you can watch it.
Oh,
so,
that's very good. That's very good. I often like to learn a bit more, particularly head and neck.
Yeah.
There's so much head and neck here.
It went very well.
I have to come to I kept saying to my head and neck colleagues that I need to go to their theater and do a bit of training with them again, but that really put off the trainees because they're all dying to go to theater, and then they don't want another consultant to come and join.
That's right. But actually went very well. Nearly 1,400 delegates attended that
Wow.
meeting. Yeah, very pleased.
Well done, Jay.
It didn't crash, but we're getting
crashed.
Yeah.
You know, my computer crashed for no reason just now. I had everything set up, ready to go. And then I was listening to Iqbal's talk, and then suddenly it just switched off. And this is, I figure I best to use the hospital, you know, our work laptop, because it's got all the up-to-date, you know, software and everything, antiviral and God knows anti whatever. And it just switched off. And I was like, no, shut down. It's
Iqbal might be using his old mini Mac, I think.
Iqbal, I think so. Maybe that's why.
It's still no. I think he's good. I think there's something needs to be done. So is Nagaraj? So, are you there, Nagaraj?
Sunil is next, isn't it? Sunil.
Yeah, Sunil. He texted me this morning. He'll join at 11:15. Yeah.
Okay.
Jai, yeah. Did you call me?
Yeah. Are you okay, Nagaraj?
Yeah, I'm okay. I'm a little bit struggling. Again, the sharing the screen. Actually, I have the same pattern. What he was describing, Iqbal was describing.
Okay.
Same what is I'll try my things. So I'm sharing now. See how it goes. Okay.
Yeah, it's working well.
So from there I can go. All right. Okay. Are you seeing the?
Do you want to just see whether your slides will come up and we can see it then?
Yeah.
Do you see the slides? Do you see the slides?
No, I don't see the slides. I can see your desktop.
That's fine. So open the slides from there.
Open your slides then.
All right. Okay. I have opened it now.
Well, it's not open. Is it open?
Yeah.
On
Yeah.
your screen?
No, you
not
close that one. You close that. You open it from the desktop. Close the
Right.
power.
Okay. Just 1 minute. 1 minute. I'll go. So stop sharing. Okay.
You don't have to stop sharing. So you just share it.
So what do I need to do now? Actually,
Okay, just share it now. Share your PowerPoint now. You've got it open. Share your PowerPoint now.
You need to talk what you're saying. Yeah. Yeah, we can
that's
see
good.
that.
We
Yeah.
can see it.
you are seeing now, yeah?
Yes, yes.
Okay.
You need to see the kind of, yeah, make it like a slideshow.
Okay.
So that, yeah, that's it.
Excellent.
Okay, that's okay. Thank you.
Yeah.
So just leave that PowerPoint on the desktop. Okay.
Right,
So
okay.
don't make it small, that sort of thing. You obviously have to escape from the the presentation kind of mode.
Okay, okay. I
And just
understand that.
leave
I
it
understand
open
that
on the
now.
desktop.
Brilliant.
right.
And do you know where you are this afternoon?
Yes.
And do you think you can move? I think you are in, I put you on room A.
Okay.
Do you think you can move by yourself? Just check it. Click the breakout room and check whether it moves for you.
Breakout room. Okay. And then
Press A.
Yeah.
And you can just go and
Yeah, I
join.
can see you now. You're in the room A. So you've moved yourself, which is great. Okay, good. So he's there.
Good.
Now he has to come out from it.
He'll come out. He'll come out. Yeah.
Sure. Do you need to help, Jay?
No, I think it's fine. I think I just given you preference, but in case if they struggle, they can. And in the bottom, the broadcast message, Linda will send you the message to everyone. But if you want, you can send a message as well.
Yeah,
Broadcast message goes to that. And on the next to that, there is a close all rooms. Please don't do that. Okay.
Did I close all room?
No, don't close all.
Don't close all room.
Then it means you just cross the box, cross the red one on the left up if it is blocking your screen. Is now Raj is back? I think you'll be back. I think.
Yes. Yeah. It is going okay. Yeah.
Yeah. Okay. Great.
Is it my SaaS screen is disappeared now? Isn't it? Yeah. It's disappeared now. Yeah.
Yeah.
Okay. Yeah. Okay. That's okay.
Even other person can share screen as well straight away. It will disconnect you automatically.
All right. Okay.
If other faculty wants to share. Yeah.
Right. Okay.
And
I think that should be all right.
Yeah, and you are covering you're covering PAEDS as well as otology. Yeah.
That's right. Yeah. That's right. Yeah.
I don't think Shankar is going to join. Richard will be doing rhinology. Yeah.
All right. Okay. That's okay.
Good.
Good.
So is Sri there? Sri Velala is gone for a coffee, I think. That's fine. Good.
Hi, Alok.
Hi.
Oh, it's Alok here. Oh, that's great.
Hi. Yeah, sorry.
Are you well?
Not really. I'm on high dose
no.
steroids and my chest is pretty bad.
Oh, no.
No.
So that's why I've been in bed most weekend. Can I see if I can share this video?
Of course. Yeah.
So I need to go to share screen.
Yeah.
And
when you see the share screen,
yeah, if I share.
And just make sure did you click the share sound option?
Now I've got
no, you already shared the screen already. So can you redo that again, please?
Okay.
Oh, yeah.
Okay, so stop share.
Yeah,
Okay.
so click the green button.
Yeah.
And when the window appears, on the left bottom, you see there is 2 boxes in the bottommost corner: share sound, share optimize video clip.
Ah, right. So share sound. Okay.
Yeah, that's important. If you click that one, it stays there.
Okay. And then,
then you proceed whatever.
then just need to get past some.
Yeah.
Let's see if this plays. Let's go.
Distract it. The rules of masking
Perfect.
are, so we've got rule 1, which is related to
The only thing to say is that
basically it's
look,
masking.
the wording is quite blur.
Yeah, that will be all right. That'll be all right. I think that's I think that's it was originally, it was like that actually. Yeah.
Threshold is below the ear conduction threshold.
Oh,
you
blurred.
probably want to get them checked,
the words are quite
checked.
blur, as
we would
in
usually
they're not very
watch
sharp
our bone conduction
looking,
placement for that, or maybe re-instruct the
But
patient.
can hear
Sometimes it does show up, but on the whole, if you're getting consistent responses where the bone conduction is below the ear conduction, something is going wrong with the testing procedure.
Sometimes. Is it blurred for you as well?
Yeah, it's blurred for me. I'm just gonna have a look because he sent me a couple of them.
But it's where rule 1 has it.
I know how to do it. I'll have a play with it now.
Rule 1 will pick
Okay.
up,
And
I'll email you.
but if there's
and one more thing,
and it's basically
you'll be moved to the breakout room. Yeah, I think.
So yeah, today I'm doing the breakout room, and I'm going to do some otology cases with them because it makes sense not to do pediatrics with them. And then tomorrow I'm going to do pediatrics, and
that's right. Yeah,
stay away from otology.
That's right. And do you know how to move to group AF session?
No.
If you click the breakout room sign on the bottom.
Breakout rooms. Okay.
Yeah. And
and then just go to there.
Yeah. And then you can move. When you reach the room, you can leave the room. You will come back to this again.
Okay. So it's not letting me go into the room at the moment. Is that just because the room's not open?
No, it's open. You need to reconfirm that again.
Okay.
If not, I can move you. It's not a problem, but you can easily move.
Breakout room. Or join. Okay. Yeah. Okay. I've got to do it. Okay. Perfect. Let me have a look, Jay, at the video you sent me 2 videos, so that maybe a better one. Okay. I'll have a look at it. All right.
If not, I will play that for you. It's not a problem. So you start if you have a problem, you can always come back and let me know.
Okay.
I can play it from my computer as well. It's not a problem. I can come in and play.
Okay, I'll have a little look at it now. All right, I'll go and do that now. I'm going to leave and play with that. Okay.
Brilliant. Thank you.
What time am I up? Not till about after.
No, you have a lot of time. So only 1:20 we'll be starting that one.
Yeah. So I'm going to go and leave and see if I can fix that now. All right. No worries.
Okay, great. No worries. Hi, Sunil.
Hi, Jay. Hi. You're right. Hi.
That's great. I think you're on track, I think. So
brilliant. Okay.
Yeah. So I'm going to play first one video. Then after that, it is only 15 minutes talk. Then after that, you will be giving you a talk. Yeah.
Yeah, that's brilliant. I mean, it's pretty short. I've used the same one, the PDF. So when I share the screen, the only thing is the PDF sort of comes as it doesn't come up as a full screen. Is that okay? Or
no, it does. It does come. You can try it now.
Shall I just share it now and then just see? Thanks. Hi, Kay.
Hi, Sunil.
You're right.
Good.
I'm just going to try and share the screen now, and then let me just pull up. So how do I?
I mean, it's fine. It's actually.
Okay. Is that right? Okay.
Yeah, just make that as a green little bit. Yeah.
Is that?
Yeah, that's better.
Yeah,
on the side one, if you click that, you can disappear that one. But it doesn't matter, to be honest. It is more than enough for us, actually. Yeah.
Okay, I'll have a little play with that and see if I can. Only
the left bar. If you remove that one, it's possible. If you click one of the buttons, it usually goes away. Yeah.
Yeah. That's I'll try that because it's just some advert for upgrading.
That's brilliant. Okay, so I'll just. So this talk is made by Miles Bannister. It is very useful to understand what the exam pattern is. During your stressful time, sometimes you miss few things. So this talk is very useful. And all of you know that there's no patience for this time as well. So the actors or actually the other examiner will act like a kind of role-playing type of scenarios, or they might show you the videos or open the conversation with some history or introduction slides. Then that's how the examination is going to be. So you can listen to this talk.
Good morning. Jai's asked me to give a talk on the structure of the part 2 of the examination, and also to provide some tips on preparing for this and some tips on answering questions on the actual day for the Viva section and the clinical section. Jai's already done a really good talk on how the clinical side of the examinations changed because of the restrictions of the pandemic. And so when I've done this before, most of the talks focused on that. But this year, I guess, I'll centre on the Viva itself, which hasn't changed very much at all. And then use the time we have to do more worked examples, which always seems to be demand for when I've done this before. So as I'm sure you know, there's 6 topics covered in each station. There's 4 stations in total of Rhinology and facial plastics, otology, neurotology, head and neck, and Pediatric otolaryngology. There's 2 examiners present at each table who take it in turns to ask 3 questions each, and whilst one's asking questions, the other will be marking your performance. How each question starts off is with a picture. It may be a video, or it may be something more nuanced like an audiogram to illustrate the questions that are going to be asked. But equally, there may be no run-in at all, and an examiner may just start talking to you about a situation or discussing the presentation of a case with you. The topics you get asked about in the Viva stations are a mixture of the very straightforward and emergencies, sometimes deceptively straightforward, difficult aspects of what we see every single day, and much, much rarer aspects of our work. The Viva starts with an introductory question, which is absolutely essential to get right really very, very quickly. So you can start progressing through the case and work towards the pass mark level of 6, and then using the time left within that 5 minutes assigned for the question to reach the higher levels, level 7 and level 8. And if you're doing well and you're very much to the point and you're able to progress quite slickly, you get moved on to different scenarios within the context of the question, and much more harder questions too. You should be prepared to be interrupted throughout, and that's not a bad thing, because if you are, it's the examiner's either moving you back on track if you've got off track or misunderstood aspects of the question, or you're doing well and they want to push you, and there's an opportunity to get the high marks on that particular question that you can put in the bank, if you will, for times when you do less well. The general tips for answering questions in the Viva section is really to stay on topic and listen to what the examiner's asking. It's really, really important not to come with a generic answer to a topic, because then you can get in a situation where you're not listening to what the examiner's saying, and it's very, very frustrating, and time's being eaten up where you're not progressing at all throughout the topic that's being asked. It's also important to answer any question that you get given in the context of a case, and think as you're answering, is what I'm saying really relevant to what I've been asked? And remember to include any key points on the topic, however, because that's also something the examiners are looking for. Of course, there's a temptation to be very quick with answering questions, and it's really important to think about what you're going to say before you say it, whether or not it's correct, whether or not it's relevant to the question too. It's also important to avoid becoming nervous and tensing up during these questions. Another tip is, if you do feel that the question's gone badly or part of the question's gone badly, detach it, forget about it, and detach each station and each part of the examination from one another, because they are all marked separately, and there's really no point, if you feel you've done poorly in one area, letting it overwhelm you and disrupting your answers and disrupting your performance subsequently. And please remember, if a question does seem hard, given all the work that you've been doing these last months and all the training you've been involved in the previous years, you're probably actually doing very well and reached level 6 already. So if you are struggling with something, please don't let that overwhelm you or knock you off course. The most important piece of advice is to ensure that you do lots of viva practice with other candidates in your region to make sure that you're familiar with the process of answering questions on during the examination. It's best to do this face to face, but increasingly because of the pandemic, this may be online. If there are any examiners who work within your region who you know and who are familiar with you, approaching them to do viva practice can be very, very helpful indeed. The reason is because they can give you very good feedback on the style, the pace, and the content of the answers you're giving, and you can refine your answers a lot more to what the examiners are going to be looking for on the actual day of the examination. In the 2 weeks before the exam, make sure that you relax, keep practicing, keep reading up to cover any blind spots in your knowledge, and practice incorporating these in your answers if need be. Make sure you get good night's sleep in the run up to the exam so you're well rested. And on the day, whatever you need to do to minimize stress, to make sure that you're giving the very best answer you're capable of. A good tip that I often give is to perform a warm-up viva with yourself and a colleague before the actual sit down with the examiners. This will mean that you're familiar with the format on the day, and it won't be a total surprise to you when you do go in with the actual examiner. This section's always leads people to ask me questions about putting more in, and the worked examples here aren't designed as being answers that you should give should you get these stations. All the worked example questions are based on stations that I got asked about 4 years ago, but they're really designed to highlight the types of questions that you might get asked through level 6, level 7 and level 8. So in this case, you'll be presented with a photograph with a lesion in the middle of the lip. You'll be asked to describe it, and you'll talk about its size, its site, what it looks like, what you're thinking it might be, and key points you'd ask from the history and the examination that you would do of this patient and why. And you would comment that this is appears to be a basal cell carcinoma. It's in a high risk area in the lower aspect of the lip. You'd want to know about previous lesions in the head and neck that have been excised, what the occupation of the patient is, are there any associated neck masses at all. Then talk about moving on to taking consent for performing a biopsy. If you are going to do an incisional biopsy, where you're going to take that from, if it's going to be an excisional biopsy, the margins you're going to use, what's the risk level for this patient. You would discuss the situation as a skin MDT possibly. Would you consider involving others such as dermatology, plastic surgery? Would Mohs surgery be appropriate for this case? And also finally, to get that level 6 mark in this question, you'd be talking about how you're going to reconstruct the defect from excising the lesion. Would you do it at the same time as you've excised the lesion, or would you wait to make sure you've got good marginal clearance? And when you do reconstruct, how are you going to reconstruct? Advanced answers for all viva questions really do depend on the question that you're being asked and what the examiners feel like asking you. The advanced questions vary a lot, whereas the introductory questions remain pretty much the same. And what I got asked as an advanced question for this particular case was along the lines of the patient presenting back to you a number of years later after the lip mass has been excised. What do you do? And then you really sort of go back in that case to stage 1, examination. What are you thinking about? Metastatic neck disease. How are you going to manage that? Going to be open surgery, followed by radiotherapy, discuss a skin MDT. And if you quote guidelines, you reach the very upper echelons of the marking system too. So that's really an example of how to approach a question like this. For the pediatric Viva, an example I got asked about was this situation, which was a 3-month-old with worsening breathing difficulties and how to proceed. And really this is an invitation to talk about history, the onset, the duration. Is it really stridor? What's the nature of it? Are there any associated symptoms? Ask about the perinatal history. What's the child's feeding like? What's their weight plots been like? What your physical examination, what you're looking for and why. If the situation is deteriorating, what do you do next? You think about intubation, you make sure you're examining for vascular skin lesions, you want to see what the work of breathing. And then in this case I was presented with this photograph asking what it showed, and it demonstrated a vascular lesion in the subglottis area in the inferior aspect and also vocal cord nodules. The question then was, what do you do as an advanced question? How are you going to manage this? In this case it was propranolol, quoting a guideline regarding that. And then further advanced questions were, well, if this treatment had failed, what would you do next? Who would you involve? Is it going to be surgery with coblation or by laser? If that fails, what do you do next? Do you consider open surgery? Do you consider tracheostomy insertion? And these are all aspects you can discuss or will be asked about in the final few minutes of that particular question. Third worked example is from the Rhinology Viva, and this one was a septal perforation that I was asked to describe, looking at its size and its site, and you point out about the mass in the right posterior rim, how there's crusting inferiorly, and discuss how you'd like to ask about B symptoms suggestive of lymphoma, constitutional symptoms possibly suggesting a systemic disease like GPA, any risk factors a patient might have for malignancy, and talking about completing the examination with a flexible laryngoscopy, examining the head and neck and the axillary and groin regions for any masses that may indicate. To complete the level 6 answer, you carry on talking about taking a biopsy from the mass and from aspects of the septal perforation, what blood tests you do, if any, why you would do them, any imaging you might undertake based on the results of the biopsy in particular, discussing the case at the MDT if it's malignancy, and if it were malignancy, how you'd manage that. Now, a photograph like this can be deceptive because the examiners may not want to talk about the mass that's present at the posterior aspect of the perforation at all. They might want to talk about more general symptoms of a septal perforation and how you would manage that. So again, please don't use my worked examples here as a rule book for what you're going to get asked should you see a photograph like this on the actual day. And for a situation like this, let's say it were a septal malignancy, the advanced questions are going to be, how are you going to manage that? Is it going to be surgery? Are you going to rely on radiotherapy? If it is going to be surgery, is it going to be endoscopic? Are you going to do open surgery? How extensive would any open surgery be? How would you manage the neck? After surgery, would you provide any post-operative radiotherapy treatment? What would you do if that failed? What might your reconstruction be? What guidelines, what evidence base are you working from? And again, if you quote those, you're reaching the higher echelons of the scoring system, and what your process would be for follow-up in this patient.
That's the end of this talk. So the bottom line is there's 3 levels of scenarios or 3 grades of questions to pass. And remember, it's only 5 minutes. You don't need to rush in, but go in a very systematic manner. I think that's it. Now, Sunil is a consultant pediatric surgeon from Liverpool, who is going to give a talk.
Hi, Jay. Thanks very much. Hello, everyone. So I'm going to give you guys a talk on pediatric ENT and just sort of going through some airway stuff just to help with for the exam. I can't see everyone, but I guess if you've got any questions as we go along, feel free to ask either via the chat function, or if you put your hand up, then you can do, or we can once we finish the talk, we can have a little chat and you can ask any questions because I'm sure some questions will arise. When I'm screen sharing, sorry, sometimes it's quite difficult to see if anything comes up in the chat or hands are up, so I might rely on Jay to just maybe help with that, if that's okay. So I will try and share now. So just give me 2 seconds. It's always a bit weird not having anyone actually there, sort of, it's just talking to a screen, but hopefully it's all working.
Perfect. Looks perfect.
Yeah, okay, perfect. Great, okay, so so as I say, it's a short talk really just on mainly sort of pediatric airway conditions, because that's one of the things that some of you may not have had that much experience or may just feel a bit less sort of confident on. So in terms of the spectrum of pathology, well, there's all sorts of things. So, you know, it's always good to kind of think about pediatric airway problems in a more systematic way. So you start off from the nose and then work your way sort of down. So you have lots of things in the nose. You know, people forget choanal. I mean, everyone knows about choanal atresia, but the most common cause of neonatal nasal obstruction is actually neonatal rhinitis. So that's, you know, that does come up in the exam. So having a bit of knowledge about that and how to manage that is quite useful. Nasal masses, although rare, they do sometimes come up in the exam as well. And craniofacial conditions. So we do a lot of work with our craniofacial colleagues at Alder Hey. So it's important to just be aware of those conditions that can cause things like congenital nasal bony stenosis. And then working your way down, so you think about children with Pierre-Robin sequence who might have some glossoptosis of the tongue sort of falling back and micrognathia. And then sort of other issues like abscesses and caustic injection, and then infections in the larynx, and then further down as well. And the sort of the asthma, pneumothorax, pneumonia, that's more sort of respiratory, but it's important to sort of be aware of, you know, all the issues that might happen in the trachea as well. So we're going to talk about a few of these things as we go along in the talk. So in terms of the history, so normally I'd ask you guys to sort of tell me what you'd ask in the history, but I'll just sort of go through it. So in terms of history, think about the noise they're making. Now, the honest truth is, in practical terms, often your parents will actually say, oh, baby's making a squeaky noise. So it's very difficult to know, is that stridor or is that stertor? Or, I mean, what is it? But often, if it's a little baby, it's probably going to be stridor, so you sort of treat it that, even if they say squeaky noise. Which is a common thing that they seem to come up with. If you can tell whether it's inspiratory, expiratory, biphasic, that can help in terms of determining the location. But practically speaking, sometimes that can be quite difficult. But in the exam, it's probably worth being able to sort of say, you know, if it's inspiratory or expiratory, where you think the obstruction might be. The cry is very important, and I mean, babies most importantly cry, but in older children, their voice as well, because I'll give you an idea of if you think there's some sort of glottis issue, either functional in terms of the cerebral palsy or vocal fold palsy, or in terms of a fixed obstruction as well, which will cause them to have a weak cry. In terms of cyanotic attacks, that's really important. So if they say the baby's going blue, then you've got to think outside of the box. So don't just think ENT, think about other causes, such as cardiac issues. So they might need an echo prior to doing an MLTV or anything like that. Feeding difficulty is really important. It's something we don't think about in adults, but in kids, so important to think about feeding, because as a baby, if you're having if you're having airway problems, you tend to have feeding difficulties because it's closely, intimately related. So really important to ask about that. Ask them to pull out their red book as well. So in the exam, for the clinical stations, just ask that when you're doing a sort of history and examination, just ask mum or dad to pull out the red book so you can look at their growth charts, because that's really important. Again, if a child is failing to thrive, it's generally, and has some sort of airway issue, generally means you're going to probably have to do something in terms of operating. If they're managing really well, then you may be able to just manage it medically or conservatively. And as really important to ask about neonatal intubation, because that can give you increased risk of subclottic stenosis and acquired subclottic stenosis. Also important to ask about whether they've been on special care baby unit, because parents may well remember that more than if they remember whether the child was actually ventilated or anything like that. Because sometimes they'll say to you, oh, my baby had a tube down their throat, and it's actually an orogastric tube as opposed to an endotracheal tube. So just asking about those things is important. Family history and usual sort of other medical conditions as well is important, because some, if the child's syndromic, there might be even more risk of an airway pathology. So that's history. Moving on to examination. Most of the time in the examination, when you're seeing sort of patient in clinic, they're not going to be necessarily actively making the noise. So sometimes a video from the parents is quite useful. So the mum or dad might pull out a video, and then that gives you a bit of an idea of whether it's stride or a sturt or what's going on. And again, you can listen to their cry as they're sort of sitting there. The ones with a hoarse cry or almost absent cry, you're thinking about vocal fold pathology, but palsy or something like that. Make sure you do full examination. So don't forget subglottic hemangioma. So if they've got cutaneous hemangioma, we'll talk about this in a bit anyway, then you need to sort of do a full body examination just to check for any of those. The ones we worry about segmental facial and neck hemangiomas, but we'll talk about that in a second. Work of breathing, where some of these babies might have a bit of recession, they might have a bit of tracheal tug, but you need to sort of mention about that. So again, you need to get them, you have a good look at their chest as well. And certain signs can sometimes suggest that they've had chronic issues with work of breathing, and cyanosis. Well, yeah, I mean, if they are cyanotic, they're looking at cyanotic, then I'd be more worried in the clinic scenario. But it's important to mention these sort of things when you're talking about the examination for an airway child. So we mentioned about nasal pathology. So babies are obligate nasal breathers, and that lasts for a good few months. So you do find that if they've got neonatal nasal obstruction, they're going to really struggle with their breathing, and you find this. So again, we're going to talk about choanal atresia in a second, and you find that does tend to be the case with babies, because they're obligate nasal breathers. Any nasal obstruction can cause them to go into extremis. Well, bilateral nasal obstruction can cause them to go into extremis. In terms of rhinitis, we mentioned about the most common cause of neonatal nasal obstruction. So just have a think about that. Whenever you're faced with a viva that talks about neonatal nasal obstruction, don't go straight for choanal atresia, because that's kind of what most people tend to do. Just think about the more common causes like rhinitis first and foremost. It may well end up being choanal atresia, but what they want you to do is to show that, if you're given a limited amount of information, then they want you to sort of show you have a systematic approach to things. We mentioned choanal atresia, which we'll go into more detail. Piriform aperture stenosis is important to mention. It's quite rare, but we do get it. Every so often we do get a baby with that, and that's the sort of more anterior stenosis, where the bone is basically just narrowed in, and that's usually associated with that mega incisor, that single incisor. So important to have that in mind. The other thing to mention is, so children with craniofacial conditions can get congenital bony nasal stenosis, which is like this, it used to be called mid-nasal stenosis, where the bone in the middle of the nasal cavity tends to be narrowed, and can cause obstruction. So for those babies, we tend to sort of dilate, and sometimes might put an NPA in to help keep that open. There's some good papers from Gosh with regards to that for craniofacial conditions, the congenital bony nasal stenosis. So it's a rare condition, but it's, if you do get it in the viva, it'd be useful to know about that. Congenital nasal masses, really important as well. So again, these are rare, but they're things like meningoencephaloceles and things like that. But just think about those as well if you're faced with a child with bilateral neonatal and nasal obstruction. And then don't forget birth trauma. So it's always important to ask about the birth history. Was there sort of forceps delivery or something like that? Because kids can get septal deformities and even septal hematomas in little babies. So just be wary of that and think about that. So choanal atresia, this is the one that most people know about. The most common thing is it's mixed. So, you have this bony or membranous, but most commonly it's going to be mixed. So you'll have an element of sort of bony atresia and then a little bit of mucosal atresia or membranous atresia as well. So most of them really truly are mixed. So making the diagnosis, well, it sometimes can be quite difficult in a DGH to look with a nasal endoscope. You might not have the right equipment, but a very simple test. You can just do a misting test, get a wooden metal spatula under the nose, even a metal spoon, to be honest with you. You stick it in the fridge and stuff, and then just pop it underneath the nose, and you'll be able to see if there's sort of misting on both sides. Some people use a sort of cotton ball, or you can use like a piece of cotton ball as well under the nose and looking for it to sort of flitter away. The other thing is passing of a feeding tube. So often, if it's a unilateral choanal atresia, the first time you'll hear about it is when the nurses have tried to put an NG tube down one side and they've struggled. So it's important that's one way of doing it, or suction catheter is the other thing you can stick down the nose. And as I said, nasal endoscopy, if you can do it, is great because that'll give you a pretty good diagnosis. So once you've made sort of through your examination, once you thought that actually this might be a choanal atresia, then you need to think about imaging. Now, in the exam, a favorite question that they like is prior to actually getting a CT scan, what do you need to do? And if you've done any of these, if you've seen any of these, you'll know straight away that you need to decongest their nose and suction their nose. So normally what we do is we actually get our SHOs to sort of pop some octravine drops down the nose to decongest, and then we also get suction catheter, because there's often a bit of mucus that sort of tends to sit in the nose. Obviously, if it's blocked at one end, you get a bit of buildup of mucus against that blocked end, and so you use the suction catheter just to sort of clean that out just prior to them having the CT scan, so 5-10 minutes before, if it's possible. And so that's quite helpful, because then that won't give you an artifactual mucosal choanal atresia, if that makes sense. So yeah, so that's useful. Just remember, prior to imaging, decongest and suction the nose. So unilateral choanal atresia normally gets picked up later, as you can imagine, because they're managing to breathe. So the obligate nasal breather as a baby is managing to breathe through one side, so doesn't really struggle too much. And so it may just be a coincidental thing. I remember when I was training, I had a 17-year-old boy who ended up he was listed for a septoplasty, and then looking down his nose, there was a choanal atresia, so a unilateral choanal atresia. So it can be quite late when they're picked up. But sometimes, even with the unilaterals, they may struggle a bit, and then somebody tries to stick an NG tube down and struggles. So, but it's important to try to just be aware of this, that unilateral choanal atresias can present later. And they tend to get this unilateral nasal obstruction and rhinorrhea. So bilateral choanal atresia, this is the one that again tends to pop up in the exams. So generally you'll be called by the scenario is generally you're sort of called by the maternity unit because they're struggling with a baby who essentially is when they cry, they sort of sort out their breathing, and then as soon as they stop crying, then they go blue, and it's a cyclical cyanosis essentially. And you can imagine that because basically when they're crying, they breathe through their mouth, but as soon as they stop that, then they're relying on their nose, which they don't have an airway for. So it is a neonatal airway emergency. So you need, the crucial thing first of all is to secure the airway. You can do that via different ways. So oropharyngeal airway is sometimes used, and taping that in place, or intubation. To be honest with you, in my experience, it's generally the anaesthetist will just intubate the child so that they're safe for transfer. Sticking an oropharyngeal airway does work, but the problem is, I think it's not a secure airway. So once you're trying to transfer a child from the maternity unit to the children's hospital, it's easier and safer to just stick an endotracheal tube in. So that's usually the way they do. But you can mention oropharyngeal airway because it's perfectly fine. They tend to have oral gastric feeding. So remember, once you're sort of, you need to remember to sort out that feeding side of things as well. So don't forget to say that you want to put an oral gastric tube in as well. And then once they arrive at your ICU, then it's up to you to sort of deal with it. And there's always often pressure to sort of get on and deal with the problem. Parents are normally quite concerned as well. So enlist pediatricians because you're thinking of charge, which again, I'd ask you guys what does charge stand for, but I can't really see, so it's difficult to do that. But yeah, enlist a pediatrician and enlist cardiologists and get all the relevant teams involved. Your geneticist as well, so some genetic testing. So interestingly enough, charge babies tend to have some anomalies of their inner ear. So usually the geneticists have told us it's not a truly pathognomic sort of sign, but generally our geneticists have said to me before that if you find these particular features in the inner ear, then you're more likely to have a child with charge. So because often you're waiting for genetics can take a fair bit of a time, but if you're getting all these other features of charge, then you start thinking that that's what it may be, particularly the inner ear finding on a CT scan. So when you do your CT for the corneal trees, you can ask them to look at the inner ear as well. And then how do you manage it? Well, surgical repair, and this is again is your so you've done your sort of MDT approach, and you're doing your charge workup and things. Echo is really essential prior to doing any surgery, but some of the other stuff you might have to wait for a little while for it to come back. And then you look at the back of the nose, and as you can see here, you can see a bilateral choanal atresia, and that's a classic sort of picture you might get. And then you're thinking about how to repair this surgically. So again, if you've done it or if you've had an experience, you'll be sort of pretty comfortable with it. But the key things to mention are you tend to use the cleft palate gag, so not the classic Paul Davis gag, because little babies obviously don't have any teeth. So the cleft palate gag is quite useful way of getting sort of access to their mouth and back of their nose. Use a 120-degree scope, so that's very odd because it's very sort of counterintuitive in terms of you're looking back on yourself, but once you get used to it, it's actually a really good way of doing it. And then you tend to so what you want to do is dilate using the urethral dilators through this sort of membranous bit, and then you can use a drill, the special choanal atresia drill that's made by Medtronic, that has a sort of shield as well. And that can be used to drill down the bone on the edges of it, and then you can use a microdebridor for any of the loose mucosal tissue as well. So those are the three things you want to be mentioning when you're talking about surgical repairs, because those are generally the three things that we tend to use. They may ask you about stents as well, and some people talk about mitomycin. We don't really tend to use that, but stents is kind of one of those things that people debate. If I'm honest with you, I think most places now have gone away from using stents because there are issues with granulation when you take the stents out, and also stent management is quite difficult in the wards. Nurses and staff are not quite comfortable with it, and so it can cause all sorts of problems. So to be honest with you, I don't tend to put stents in, and I think most of my pediatric colleagues don't tend to put stents in anymore. And we just basically bring them back to theatre. At the beginning, it's almost every couple of weeks, essentially, just to sort of open it up. But then they kind of, it's a bizarre thing with choanal atresia. They sort of get to this point where they just sort themselves out, essentially. And then you stop having to take them to theatre. So the first sort of month or two, you're stressing out because you have to take them to theatre every so often. And then suddenly they just find a way of, settling down. And then you just, it's literally, then you hardly ever have to take them to theatre. But it can be a tough first few months. So I normally counsel the parents about that as well. But first few months are quite difficult. Charge, well, there you go. That's what charge is. And I'm sure you sort of all know about it. It's a syndrome because it's been noticed to have a underlying chromosomal malady. In terms of laryngomalacia, now this is a common problem, and then one of the most common airway issues. We describe as a floppy larynx to parents, and typical history is important. So they sometimes get a bit refluxy, and it's positional. That's the key thing. And the key thing to do is, once you made the diagnosis, you can reassure the parents that it's probably going to get better. So the only times you intervene are if they're having blue episodes, cyanotic episodes, if they're really struggling with their feeding, failing to thrive, and those sort of things. There's two variants. Important to just be aware of it. The anatomical variant, which is the most common one in a healthy child, and that's the one where you can do a little snip, and we'll talk about that in a second. And there's a neurological variant. So that's the one when they probably have a syndrome, like say, for example, charge, and they've got reduced tone, or they're neurologically impaired. That's the one where you don't want to surgically intervene, because then they'll start aspirating and it causes more problems. But again, we'll talk about that in a second. So look at their growth charts. Just get used to these growth charts if you're not used to them. Understanding how, being able to sort of, I guess now you don't sort of physically have to look in the red book, but in the past, you might have to sort of pull out a red book and then find the growth chart quite quickly. And you can tell when people know about it or not, because they'll straight away go to that relevant page. So this is a classic sort of picture where you're worried that this child is failing to thrive, and therefore they might need some, with laryngomalacia, they might need some intervention. As I said, cyanotic episodes, apneas, and really struggling with their work of breathing are indicators to operate on them as well. So how do you diagnose this? Well, you can do a fiber optic laryngoscopy, which helps to rule out other pathologies like a molecular cyst or focal cord paralysis. And remember that you can get concomitant airway issues. So just because there's laryngomalacia doesn't mean necessarily that there isn't anything else like subglottic stenosis or something like that. And then that's the anatomical variant of laryngomalacia. That's a lovely one, nice curled epiglottis, short aryepiglottic folds, and the arytenoids generally can be quite full. So the way you can operate on that is an ML. Subglottis as well. So yeah, it's worth doing an MLTB. As we said, the aryepiglotticoplasty or supraglotticoplasty initially is those sort of things. Just be wary with the neurological ones not to trim them, because they'll start aspirating. Get a SALT assessment for these kids, and you may end up having to do a tracheostomy in these children. But what you don't want to do is go and start to trim them, because they'll have complications from that. And these children are generally quite complex anyway, so you want to minimize those issues. So this is sort of, well, a child with charge. You can see it's very round, sort of falling back, and very bulky arytenoids there. So these are the ones that you don't want to trim or snip, or whatever you want to call it, because they can cause problems. So vocal cord palsy, that's an important one, and it can be unilateral, bilateral, and often can be associated with other things. Just it's important to be aware of that. If it's a classic unilateral post-cardiac surgery, then that's fine. You think, okay, that explains most things. But if you get bilateral or unilateral and you don't really have a specific cause for it, then just start thinking about other anomalies as well. So in PAEDS, it's all about sort of the MDT approach and just thinking about other specialties. And normally in pediatric hospitals, where everyone's quite friendly and it's quite easy to speak to colleagues from other specialties, they're normally helpful. So in terms of symptoms, well, if you've got bilateral cord palsy, you get this high-pitched and stridor. They can have apneas. So some of these kids, you'll end up doing sort of sleep studies, and you'll see that they sort of drop their SATs at night time. You can get paradoxical vocal cord function, or this sort of it's slightly older kids as well as babies, where you have during inspiration the cords close and they open during expiration, so that causes issues as well. And with those children, sometimes you get them with the older teenagers. It's exercise-induced laryngeal obstruction. These sort of high-performing athletes who are teenagers. Just bear that in mind, that paradoxical function. The way of diagnosing that is obviously while they're having an acute episode, you want to look with the flexible scope, and then you'll be able to see that paradoxical function, i.e. they close during inspiration. So just keep that in mind as well. Sometimes it can be neurological issues that cause that. Sometimes it's just one of those things. So vocal cord paralysis, in terms of unilateral, they tend to have this weak cry, this breathy, hoarse voice if they're a bit older, and they'll have feeding difficulties. Sometimes, they need a speech language assessment to see if they're aspirating. A lot of them can compensate with just the unilateral, so they just use the other side to compensate to close their glottis. But sometimes they can aspirate, and then they may need like an NG and bits and pieces like that. The classic one is after cardiac surgery, they'll have a left cord paralysis, which, interestingly enough, if you follow them up long enough, it actually tends to get better because children seem to recover very well. So how do you diagnose it? Well, awake fiber optic is the best way of doing it because you can get sort of real-time diagnosis. You can do an MLTB, but you need the anaesthetist to kind of lighten the patient so they start sort of moving their cords. Sometimes it can be take quite a while before that happens. So you have to be a bit patient about that. The other thing is with the MLTB, the advantage is you can just rule out a cricoarytenoid joint fixation, which can sometimes look like a cord paralysis. Imaging wise, we tend to get an MR off the head. You can, in little babies, you can actually do an ultrasound because you're thinking about Chiari malformation. So an ultrasound of the head will be able to sort of give you the answer. The thing is, at the end of the day, if the ultrasound is negative, you're still going to do an MRI scan. So to be fair, most of these end up getting MRI. But an ultrasound, a cranial ultrasound, is quite a useful screening tool. And then laryngeal ultrasound. Now, so there are some units. I think it was Haitham Kuba in Abapo recently mentioned that he just does laryngeal ultrasound for all of his patients. He doesn't even bother doing awake fiber optic laryngoscopy. So I think that's increasingly popular now. And if you've got somebody who can do it properly, it's actually a very useful tool to be able to diagnose cord palsies. I'll be honest, I haven't got the experience with laryngeal ultrasound, but there are some units where they are using it a lot and very successfully. So you can mention that in the exam as well. So this is recurrent respiratory papillomatosis at juvenile onset. So this is another important one. They tend to be HPV 6 and 11, and they can present it in all sorts of ways. Some can present in extremis, basically. So kids been sort of plodding along, and suddenly they turn up in A&E with an almost near obstructed airway. And some of them might present with a hoarse voice, weak cry, and a bit of stride or a chronic cough. So just when you hear that sort of history, just think about whether it's recurrent respiratory papillomatosis. If you can do a flexi-scope, you'll be able to sort of get the answer from that. So cesarean section is not particularly protected. There's a bit of debate about this in the literature and things about whether or not it is sort of protected. But I think the feeling is not. In terms of surgical options, there are multiple options. To be honest with you, we tend to use a microdebrider. So one of our colleagues, Mr. Adam Don, tends to do a lot of RRP work. It's quite he's set up a registry nationally for that. But he tends to use a microdebrider, and that's kind of the way we tend to manage RRP. Important thing is to try and preserve the airway. So you don't want to go too far and then start going into the vocal folds, because then you'll cause long-term problems. And the key thing is that these kids, you need to counsel parents, they are probably going to need a fair number of procedures, because it does come back. So they need to sort of know that what to look out for in terms of coming back to the hospital. And they tend to so one of the questions Emil asked you is about adjuvant therapy. There's a lot of work going on with regards to this. So you think about adjuvant therapy when you're taking them to theatre a lot, as you might expect. and then when it's going further down in the lungs. So poor prognostic things are when it's into the trachea and further down in the pulmonary system. And there are some children who they have malignant transformation, and sadly there is a risk of death with these children. And so every so often some of these kids will have really aggressive RRP that has malignant transformation, and they pass away. It can be rapid regrowth and airway compromise. So as I said, you just need to warn parents about that and when to come to the hospital. It's just some of the examples of adjuvant therapy and how they work. You don't need to know, to be honest with you, much detail of this, but just to be aware of the different options and particularly maybe the first few. So usually does get better as they grow older, but it seems to sort of really get aggressive around puberty time. Fair few debulking procedures, and it does spread extralaryngeally in about a third of patients. Tracheostomy might be needed in those more severe ones, and there's some debate about whether it activates distal disease by sort of opening the airway. But if you need to manage the airway with a tracheostomy, you just have to get on with it. And as I said, malignant transformation is rare, but it is fatal, unfortunately. And so it's important to biopsy them the first time you see them. Take a biopsy, send it off for histology just to confirm that it is RRP and to confirm there's no malignancy. I think some people will biopsy every time they're taken to theatre, but I think definitely the first time you see them, you should biopsy. Bad prognostic markers were HPV-11 infection if it starts very early, and cesarean section, but apparently I think something's come up on the chat. Non-surgical. Oh, okay. Yep, I can do that at the end. Yep, no problem. I'll go back to that non-surgical management. No problem. So subglottic hemangioma. Just important to mention this one. This is quite a good one for the exams. So 50% of patients with subglottic hemangioma have associated head and neck cutaneous hemangiomas, but the converse is not true. So that's important to mention that just because you have a head and neck cutaneous hemangioma, segmental one, does not mean you necessarily have a subglottic hemangioma. But if they've got a history of stridor and that, then you should be thinking about taking them to theatre for an MLTB. Presentation seems to be around 6 weeks, peaks at then, and they get this progressive stridor, might have this history of recurrent croup and feeding difficulties, failure to thrive, and it tends to be the left lateral subglottis, bizarrely enough. It is one of those things, we don't tend to necessarily biopsy it, but I mean, it's a capillary thing, so it's not as, it's not going to bleed like crazy, but I mean, if you see this, then you know what the diagnosis, you don't need to sort of take a biopsy. And as I said, it tends to peak about 6 weeks, but then by about 2 to 3 years, it seems to settle down. There's some nice papers on propranolol, and I think my previous colleague, Mohs, was talking about propranolol. It was an accidental discovery, bizarrely enough. It was a cardiac kid who ended up having propranolol for something else, and also had a subglottic hemangioma, and they just magically got better in terms of subglottic hemangioma. But it's transformed our management of this condition. And I mean, there's different sort of theories about the precise mechanism of action. But the important thing is to understand that you need to do some tests prior to starting it. So because propranolol is a drug we don't normally use, I normally get either the dermatologists or the plastic surgeons involved, because they have lots more experience. They do a pre-op or pre-starting ECG, they'll do an echo, they'll check the BMs, because hypoglycemia is an issue with propranolol as well. And you start off at 1 milligram per kilogram per day the first week, and then you can up it to 2 milligrams per kilogram per day. And then duration is based on clinical response. And again, like I said, I'll hand it over to our dermatologists or our plastic team, who know much more about this and manage it much better than us. And there's a nice paper from Gosh as well about propranolol use for subglottic hemangioma. So these are some of the side effects, just you need to know them. They're the big ones to remember: hypoglycemia, bradycardia, hypotension. Hence, we do all these pre-starting tests. Subglottic stenosis can be congenital or acquired, so babies can be born with it, especially syndromic, or acquired if they've had a previous intubation. What you want to do is try and minimize the duration of intubation. That will reduce the risk. And using nasal tubes, uncuffed tubes, tends to be better, because you imagine nasal tubes sort of going straight down, with an oral tube kind of has a bend, and then so it's more likely to kind of dig into the side walls. There's a Meyer cotton grading system. Easiest way is 0 to 50, 50 to 70, and then 70 to 99%, and then grade 4 is no lumen. And so you get these various different sort of appearances. In terms of management strategies, so there are different, sorry, somebody's asked about management options if the panel does not regress to subglottic hemangioma. Great question. So we tend to go straight then for open surgery. I know some people have talked about coblation, so some of my colleagues in other centres sometimes use coblation and other things, but we tend to just go for an open, so you basically do a laryngeal fissure, i.e. you just open up the larynx and then you scoop it out. It's a very nice procedure actually, and very successful if you do it openly. It doesn't bleed very much at all, surprisingly enough. You just have a bit of adrenaline ribbon gauze, and it seems to get better. But that's generally what we'll do if the propanol doesn't work. But you have to give the propanol a bit of time to work as well. And generally, what sometimes if they're really bad subglottic hemangiomas, we'll keep them intubated on ICU, start the propanol, and then if you start getting a leak, then that's a suggestion that actually things are getting better. So yeah, sorry, I'm going back to ways of managing subglottic stenosis. So you have all these sort of endoscopic approaches, balloon dilatation, and even doing sort of posterior grafts endoscopically. And then you go for your open options, which is things like laryngotracheal reconstruction or coracotracheal resection. So it's LTRs generally for the less severe subglottic stenosis, and CTRs for the more severe. And they may need a trachea, that's important to remember, temporary trachea. Congenital laryngeal webs. So these are uncommon, and basically it's just a laryngeal failure of the laryngeal recanalization. It can be associated with other things, so it's important to just think about other causes as well. So other syndromes that it can be associated with, mostly clotic, and they tend to have airway obstruction. They might be a bit hoarse depending on the extent of the laryngeal web. They might have some aphonia as well. A complete laryngeal atresia is quite a scary one when they're born, and they're the ones that you need to do an emergency tracheostomy, because obviously you just got to bypass that obstruction. Way to diagnosis is flexible laryngoscopy, and then you might need to do an MLTB to rule out any other coexisting issues like subglottic stenosis, which can be common, but which can be present with a web. So in terms of web management, well, if it's a thin thing, you can just do sort of incision and dilate, and then normally just make a little cut, and then use balloon and dilate that out. There are some cutting balloons nowadays which actually have little sort of blades on the actual balloon that you can use as well. And more significant, you might need to keep doing that on a regular basis. And then if it's getting more complicated and more of an issue, then you might need to start thinking about having to do a more complex operation, open operation like an LTR. If it's really significant, like I said, we might need to do a tracheostomy. I mean, if it's completely occluded, if there's no larynx, if it's an entire sort of complete web, then they'll need an emergency tracheostomy. That is it. I'm just going to go back to that picture. I think somebody was asking about adjuvant therapy. So, great. Okay. Thanks very much. Are there any questions?
Hi, do you recommend taking out posterior part of Mohs in corneal atresia surgery?
Yes, absolutely. Yeah. So backbite, yeah, using the backbiter. We have a little pediatric backbiter. Absolutely. I do tend to say that, and that becomes an issue for stents. So if you start taking out lots of the voma, you can't put a stent in. Because it's obviously not going to sort of, you need the back of the nose essentially. But I think taking out the posterior part of the voma does tend to reduce the risk of having to take them back to theatre more commonly, and tends to reduce the risk of what's the word? Restenosis.
Okay, thank you.
Thanks, no problem. I'm going to stop sharing just because hopefully that's enough time for you guys to.
Sorry, Sunil, there's one question about you can ask the question. Can you please put back on screen non-surgical treatment of RRP?
Oh yes. I think that's what I'd put up the that
Oh,
slide.
done. Okay.
Yeah, hopefully that's enough time for it. But if not, just let me know and I can put it back up again. Yeah.
Can I ask another question about the cranial atresia? Is
Yeah.
there perhaps have you had a very prem baby born with that? Is there a minimum age, weight, hemoglobin type situation?
Yeah.
Or do you just get on straight away?
Great question. So the way I was taught, gosh, and kind of where I've sort of my way of thinking is you tend to say, well, if it's if it's a prem baby, try and avoid doing anything on a prem baby. Let them grow to term and then intervene. Obviously, sometimes that doesn't quite work out, and you because there's pressures on ICU will be pressurizing you to do something because they want some sort of solution. But as much as possible, I would suggest that you keep pushing it until they get to term, if possible. Just because working on prem babies is very difficult. Our instruments are small, but they're not. They're not designed for prem babies really. So you can really struggle with it. But yeah, I mean, from a practical, so from an exam point of view, say try and wait until their term essentially and let them grow, and that applies for any airway issue. But the reality is sometimes that it may not be possible. Hopefully that's answered.
Great, thanks. Yeah, and do you mind? Can I just ask if you're doing supraglottoplasty or epiglottic work for a laryngomalacia?
Yeah. Is
laser your preferred modality, and what do you do about airway in terms of tube and tubeless field if you are using laser? Yeah, so no, great question. So the laser is not so cold steel. I use cold steel and a bit of adrenaline soak swab. The Americans, I think the North Americans tend to use laser. So BAPO recently, we had some talks by them, and they tend to be more laser keen. And there may be a few individual units where they are using laser, but for most places, as far as I know, is cold steel, and I tend to use cold steel. So that's much easier to sort of manage. But one of the things you can do is if you've got an epiglottis that's kind of flipping down, is you can do a bit of bipolar to the what's it called, the molecular edge of the epiglottis, and it sometimes flips it up as well. So sometimes those ones where you've done the snips and they've still got a prolapsing epiglottis, just put a bit of bipolar on that molecular edge and it just flips it up, and that sometimes works as well. But I don't use laser at all, so I don't have any experience of that. But, yeah. Okay, thank you.
Okay. Sorry, and after excision of subglottic hemangioma, any reconstruction from mucosa? No. So you literally, what you're trying to do is trying to sort of retain that mucosa and just sort of cutting into that, and then so it opens up, and then excise out the subglottic hemangioma, and then relay it, and then we always tube them so as a stent, kind of just to allow it to heal. And the mucosa heals pretty well, actually, surprisingly. So a lot of babies do seem to get better. So yeah, there's a question about should we wait until ruling out a serious cardiac congenital issue and then fixing a cranial atresia? So very much guided by the anaesthetist. So if an anaesthetist says to me, so they've got some cardiac issue, say charge baby, if the anaesthetist says, look, it's too risky to proceed with surgery with GA, then I wouldn't. Obviously, then that kind of answers that question. But it's a balanced decision. This is where the MDT comes in massively, because you get the cardiologist down, you get the ICU team, and you get us as well, and the anaesthetist, and then we have a discussion about that. But generally, our cardiac anaesthetists are very good, and they just kind of will operate on anything. So we don't tend to have an issue, even if they've got some bizarre cardiac problem. We will tend to say, well, choanal atresia, sort that out, and then we can get them sort of at least sort of attempt to extubate them and things like that. But yeah, so generally our anaesthetists are quite happy to operate, even if they've got complex cardiac issues. How do you answer the question on discussion on intubation for pediatric airway emergencies? I'm not sure. Did you mean as in how do you? So MD. I mean, sorry, I don't know if is it Krishnan is there if he wants to ask physically, because are you saying in terms of just sort of getting an anaesthetist there an emergency situation, or your stepwise approach. Is that what you mean? Or I don't know if you want to speak to us, or it might be easier. But I mean, I think if the question is on how to manage pediatric airway emergencies, it's stepwise approach. So obviously, first off, you get your anaesthetist down there, and they'll try and intubate. They have various different things. They've got like schema. Oh yeah, sorry, is that somebody speaking? No. But yeah, so pediatric anaesthetists will try sort of various different methods, and then we get involved as well. So we'll try, we've got different options. You can try and do an MLTB and stick a Hopkins rod, a tube or a railroad on a Hopkins rod and try and put that in. You can use a rigid bronch, and then obviously a tracheostomy. So it's a sort of stepwise approach for how you manage that. But obviously anaesthetists would be the first line people. If restenosis after choanal repair, what is the option? So if restenosis, so that does commonly occur, like I said, especially because we don't tend to put stents now in a lot of units. So I always book them in for like a relook in 2 weeks' time, and the first time you'll often find there is a bit of restenosis. But I think the important thing is to just get them in early. So if they keep on failing, there are different options. So you can put stents in at that point, because then that gives you about 6 weeks, at which time the child will grow. But you've got to be wary about the fact that there's not very good management of stents on the ward. And mitomycin C is discussed, but as I say, we've not had to use it for any of our choanal atresia repairs. I think the key thing is just getting them back in on a regular basis to begin with, and you just have to persevere with that, be a bit patient, and then eventually they just sort themselves out. And literally after about 2 months, almost all of them just settle down for some bizarre reason. I guess because their nose is big enough then. But yeah, so Hussein said, thanks, great, thanks. Okay, brilliant. Okay, I think that's hopefully it. Yeah.
Brilliant, thank you. That's great talk, Sunil, and I'm grateful to you.
No, thanks very much. Cheers.
Good. So now we have David, who's going to give a talk about rhinology. And there is one more chat question we can reply in the chat box, and Sunil will be. David, do you mind share the screen, please?
Yeah.
Thank you very much.
All right, can everybody hear me and see the screen?
Yep.
Perfect. So thanks, Jai, for inviting me to give this talk. My name is David Alul. I'm one of the ENT consultants in Glasgow, and my talk is on top tips for CRS, EPOS, orbital cellulitis, and ARIA. So I'm not going to go. So I'm not going to be going through these publications in detail. I'm just going to be touching on the important aspects of these with respect to your viva. I'm going to be talking about these three publications really. EPOS 2020, which is I think a 500-page document. The ENT UK Orbital Cellulitis Management Guidelines, much more concise, 1 page, very easy to read. And also the document on allergic rhinitis and its impact on asthma. So this is the type of thing you don't need to bother about when you're going for your viva and when you're preparing for your viva. It's, as Miles Bannister said, you need to be concise. You can't waste time and ramble on unnecessarily, and there's just no time for detail. If you think about this logically, for each station, you've got 5 minutes and approximately 5 questions. And that means your answers are approximately 40 to 50 seconds per answer on average. So you just really need to be concise and don't waste your time. So let's start with EPOS 2020. For those of you who've not read it, it's free of charge. You can just download it. You probably won't have time to read the whole document. If you don't have time, I would just suggest reading the executive summary, and it contains most relevant aspects of management of CRS and ARS. Just a few things to be absolutely sure of before you go for your exam. Make sure you use generic drug names and know the doses. So fluticasone furoate and propionate, know the doses. I would just stick to the 3, the Avamys, Nasonex, and Flixonase, so furoate, propionate, and mometazone. They're all very safe to use long term. The bioavailability, the systemic absorption is very low, and the dose is the same. It's 2 puffs each side once daily, and for Nasonex you can go up to a double dose if needs be. For oral steroids, make sure you know what dose you're going to use. If you're asked what dose are you going to prescribe, I use 25 milligrams daily for 2 weeks for CRS with nasal polyps. So make sure you've got a sensible drug and a sensible dose to hand. So you avoid saying, well, you could use 20 and then tail down, you could use 30, etc. And also with saline rinses, again, just stick to one thing. I use a high volume, low pressure device such as needle meds and a recipe which I give to patients. So these are things that can be prepared in advance and that can save you time. Make sure you know the side effects of the drugs. The commonest side effects are epistaxis, dry nose, burning, and make sure you know the risks of oral steroids and macrolides, so you can get those off your BNF. In the questions you're going to, in your answers, rather, you should focus on management, not on etiology and not on pathogenesis, and also make sure you're able to talk through a CT scan. You probably will be asked, talk me through the scan. And also bear in mind that this is not reality, this is an exam. So when you're asked questions like, do you see your patients post-op? Don't say, oh, our clinics are too full, we can't see post-ops, etc. So just say, yes, I see my post-ops at 2 weeks, and I see them for X, Y, and Z reasons. Another comment which delegates sometimes use in FRCS mock vivas is, our ophthalmologists are too busy to see a mild periorbital cellulitis. Again, just assume that you live in an ideal world where resources are not limited, and like that you can say that your management is what it should be. It also saves time. Okay, and also be concise in your answers, as I said. Avoid the urge to ramble on. You don't get points for talking, you get points for answering the question and moving on to the next question. If you do forget something really important, they're going to say anything else, anything else. If you're shown a CT scan of a unilateral maxillary sinus opacity and you give the commonest diagnoses, odontogenic sinusitis, inverting papilloma, and you forget about chronic fungal, they're going to say anything else. So I think being concise is more important than being overly detailed and wasting your time. You need to know the definition of CRS and ARS. The distinction is the cutoff point is 12 weeks. So anything lasting for more than 12 weeks is chronic rhinosinusitis, and you've got your 4 cardinal symptoms. You can get this slide from anywhere. The nasal obstruction, nasal discharge, facial pain, and hyposmia. Okay, and you have to have at least one of the nasal obstruction and or nasal discharge. In children, cough substitutes hyposmia. And in addition to the 2 of the 4 cardinal symptoms, you must have either endoscopic signs or CT changes, or both. And CT changes means a Lund-Mackay score of 5 or more, unless it's a unilateral isolated sinusitis, in which case even a score of 2 is significant. And the endoscopic signs are middle meatal edema, middle meatal polyps, mucus or mucopus. One thing you need to know about the new EPOS guidelines is the classification of CRS. So EPOS 2020 divides CRS into primary and secondary. So this is just like primary and secondary hypertension. Primary is idiopathic. Secondary means that there's a known cause for the CRS. And in primary CRS, the CRS can be divided into localized or diffuse. And localized doesn't necessarily mean unilateral. It means that one functional sinus unit is involved. Okay, so an isolated maxillary sinus opacity would be localized. An isolated maxillary anterior ethmoid and frontal sinus opacity would be localized. Diffuse bilateral CRS often refers to what we consider box standard CRS with or without nasal polyps. So that would affect both sides and all sinuses equally generally. Right? And you've got the examples of the phenotypes written there. You can go through this at leisure. And then the secondary CRS, where there's a known cause. The commonest, at least in my experience, is odontogenic, chronic fungal, and inverting papilloma causing a unilateral isolated sinus opacity. And then you have less common causes. I would say the second commonest cause would be selective immunodeficiency or patients on immunosuppressive drugs. That's a growing endotype of or growing phenotype of secondary CRS. And then you have the less common cystic fibrosis, PCD, GPA, and EGPA. So I would have this slide in mind. Make sure you go on EPOS and just study this slide, because it would give you more points if you can endotype the CRS when managing patients, and just know something small about what type 2 inflammation is characterized by the predominant cytokines are IL-4, 5, and 13, eosinophils, and mast cells. And it's the most prevalent type in the UK. It's the most likely one to be associated with asthma, atopy, or NERD. And there's a few other characteristics of type 2 disease. So just have a very brief understanding of what these type 2 endotypes are. You don't need to look at the arrow diagrams, the complex arrow diagrams. When you ask about how you're going to manage patients, you make sure you use evidence-based treatments, okay, which are evidence-based and which the EPOS group recommends. So intranasal corticosteroids, saline, a short-term course of oral steroids are the commonest. And then the rest are also evidence-based. Corticosteroid-eluting implants you could use after first, dupilumab, mepolizumab, aspirin treatment after desensitization. Again, that's shown to be effective, but it has high side effects. The gastrointestinal side effects are a problem. And you can even use decongestants, actually, temporarily only for CRS exacerbations. You've got other treatments where there's insufficient evidence, or treatments where EPOS advises against. The insufficient evidence column is not a column that you should not use, okay? So you can use short-term antibiotics in select cases in CRS if there's an infective exacerbation. Omalizumab, there is lots of evidence that omalizumab is useful, particularly in the patients with really high anti-IgE, etc. And just have an initial your own personalized regime, okay? So when you're asked how would you treat this patient, you won't have to go through, oh, you could do this, you could do that. You just say, I would use this, this, and that, and I'd use this dose for this duration of time. So this is an example of my initial regime for ECRS, which is quite, in patients with a high symptom burden, which is quite standard. So I'd use saline rinses, high volume, low pressure. I'd use prednisolone 25 milligrams daily for 2 weeks, and I wouldn't tail down. I'd then go on to fluticasone propionate, nasals for 6 weeks, and then a spray once daily for 3 months. I'd tell the patient to stop smoking and educate the patient on delivery method, compliance, and on the disease itself. And I'd review them at 4 months to assess for response to treatment. Know something about dupilumab. If you're being asked about dupilumab, you're probably doing quite well. And you should know the indications for biologics, such as dupilumab, and these are listed in the first chapter in EPOS. Have a look at them. Essentially, if somebody has had maximal medical therapy, whatever that is, it's very poorly defined, and someone has had adequate thorough surgery, and they still have a high symptom burden, which is defined as a SNOT 22 score of more than 40, then you could consider biologics. Side effects of drugs, make sure you're familiar with them. Macrolides, okay, you've got the QT prolongation, arrhythmia, using them. So simvastatin is a very common one. Make sure you stop it if you're giving macrolides temporarily. And the evidence for macrolides is still, we're still not 100% sure whether they are effective. And at present, what we think is that in patients with normal IgE and normal eosinophils, so non-type 2, they tend to respond better. Oral steroids, again, EPOS does not dictate any specific dose, I would suggest 25 milligrams daily for 2 weeks. And the reason for that is if you look at the studies, or even the studies that use that dose have a significant effect, so there's no point going up to 40 milligrams. And if you're talking about dupilumab, the main complication at present is conjunctivitis in patients with atopic dermatitis. There are other complications, and there are complications we don't know about. If you're advising surgical treatment for CRS, you ideally offer this in a patient with a moderate to severe burden of disease. So that means a SNOT score greater than or equal to 20, okay? Lengthy, there are a few rules with respect to surgery. If you've decided you're going to offer surgery, there's no point waiting 3, 6, 12 months. Lengthy delays are detrimental. This is really important. Tailor the extent of surgery to the extent of the disease. So if a person has a pansinusitis with every single sinus involved, an uncinective, an MMA, and uncapping of bulla is suboptimal treatment. You need to target all sinuses in that case. And obviously, if you have an isolated sinusitis, you just deal with that specific sinus. Yeah, have a prepared pre and post-op plan, okay, which can be justified by the evidence available. If you're asked, is FES effective? And they do sometimes, the examiners do sometimes take on the role of a patient, and they say, well, do polyps not regrow? This should be clear in everyone's head. There's a large body of evidence that demonstrates that there's significant improvements in quality of life after endoscopic sinus surgery, particularly with nasal obstruction, facial pain if it's there, provided the pain is caused by sinusitis, postnasal discharge, sleep and asthma control. And PACs, I hardly ever use PACs, hardly ever. I would suggest not using PACs routinely. When you're consenting for surgery, you should be aware of the risk. The commonest risk is bleeding, recurrent of disease, or treatment failure, so poor adhesions, epiphora, and CSF leak and orbital injury. There's a wide variation of quoted incidence rates. I tell patients the risk is 1 in 5 to 600. And usually, and I explain that that's a generalized, that's a general value. You could be asked how you manage what you do during your surgery. What would you do? What instruments would you do? Stumbling blocks to FES, controlling intraoperative bleeding, and these are all evidence-based measures to reduce intraoperative bleeding. Some of them are preemptive, so preoperative steroids. I give preoperative oral steroids to all my CRS with nasal polyp patients. That's evidence-based. Reverse Trendelenburg, good surgical technique, topical agents, they're all very effective. Hypotension and bradycardia. TIVA, that's a really important one. So propofol and remifentanil, it reduces the cardiac output without causing vasodilatation. Tranexamic acid, IV intraoperatively, greater palatine canal injection. It is evidence-based. I've never done it. And fibrin glue or Flow-C. So just have an idea of what to say if they tell you the patient's bleeding too much. What do you do next? Okay. This is an example of a post-op care regime. Patients advise on bleeding, oozing, how much time to take off work, analgesia, advise on what medication to take, at what dose, and how frequently. And I would advise seeing the patients in 2 weeks to assess compliance with medication, access to medication. Don't assume your patients will use the medication just because you've prescribed it. Assess for adhesions and manage them if present. Assess for complications such as infection. It's not unheard of at all. I wouldn't say you see them in clinic in 2 weeks for decrusting. I don't think there's any evidence behind that. A few other points on rhinology in general, really. Should you use a flexible or rigid endoscope? Traditionally, you should use a 30-degree rigid endoscope. I think with today's flexible endoscopes, or the good ones at least, you should have an excellent view And I don't think anybody is going to penalize you for saying you use a flexible endoscope, particularly if you want to examine the throat at the same time. Swabs, bacteriology swabs, would you swab or not? Nasal swabs taken without an endoscope have a very poor correlation with endoscopically directed middle meatal swabs. So really only take a swab in theater from the sinus itself, or in clinic if you're using an endoscope. Do you need to perform a biopsy at each surgery for recurrent cases? That's controversial. There's no correct answer. Use your clinical judgment. And understand the Lund-Mackay score. Understand how to, it's from 0 to 24. A score of 2 or less has an excellent negative predictive value for CRS, and 5 or more has an excellent positive predictive value. You might be shown a scan in someone with facial pain with a score of 1 or 2. That's insignificant, as you know, unless it's an isolated or pacified sinus. And also understand what the SNOT-22 score is. It's the most appropriate instrument in measuring disease-specific quality of life, and understand what the scores actually mean. So 8 to 20 is mild, less than 8 is normal, 21 to 50 is moderate, and greater than 50, a score of greater than 50 implies severe disease. Okay, and you should also know what the minimal clinically important difference is, and it's 9 or 12. So that's EPOS. ENT UK, orbital cellulitis management. I think this is really straightforward. It's just 1 page. You can just print that off. It's when you assess a patient with an adult patient presenting with periorbital cellulitis, management is, well, at least my management is very similar to that flowchart I've just shown. There are some indications for admitting patients, some indications for imaging patients, particularly if there's signs of CNS involvement, signs of orbital involvement, such as proptosis, reduced visual acuity, if you're unable to assess the eye, or if a patient just doesn't improve within 48 hours of IV antibiotics. And when you ask for your scan, the examiners are going to tell you, what do you ask for? And it's a contrast CT of your orbit, sinuses, and brain. Don't just say a CT sinuses, because you'd end up getting a non-contrast scan, which is useless. Your management, the IV antibiotic management, is going to depend on local sensitivities. So I use tazocin often, unless there's a specific reason not to. And you should get an ophthalmological review in any patient presenting with periorbital cellulitis. Surgical management, if there is an abscess, now you don't always have to take a patient to theater if there is an abscess. EPOS says anything up to 1 mil, so 1 by 1 by 1 centimeter, can be managed conservatively. I think I'd be a bit reluctant to leave a patient with an abscess that size in his orbit on IV antibiotics. So, I mean, I do sometimes for conservatively, but normally I take any abscess in an adult to theater. And the approach depends on the skill set. So I would advise an endonasal approach, an endoscopic approach, where you decompress and you treat the infected sinus. So if it's the maxillary sinus, you need to do an
We have an implantable devices service which offers assessment and fitting. This is for bone conduction devices or middle ear implants. We don't do it for cochlear implants, although we provide the assessment and some speech assessment and audiometry assessment for the cochlear implant centre. But all the cochlear implants are done at a national centre in Kilmarnock in Scotland. We've got paediatric diagnostic assessment, so we start testing our hearing.
Rhinitis. There is no impairment of sleep, impairment of other troublesome symptoms. Right. And the duration, the cutoff point is for 4 days a week or for more than 4 weeks. And you've got your flow chart on the management of allergic rhinitis, allergen avoidance, and irritant avoidance. It says may be appropriate. There's actually not much evidence that, there's very little evidence that allergen in all my patients. First line treatment is an intranasal corticosteroid spray, saline, so topical saline, an oral antihistamine or intranasal antihistamine could be added on, chromone eye drops for eye symptoms, ipratropium spray for rhinorrhea, and immunotherapy, sublingual or subcutaneous. If you do get down to the immunotherapy part of the flowchart, just say, I would just say that you're referring on to an immunologist for it. And that's the end of the talk. It was a bit rushed, but I just tried to cover everything. Are there any questions? I can't hear anything.
Hi, can you hear me?
Yes, yes.
Yeah, what approach do you prefer in draining subperiosteal abscess in children, open or endoscopic?
What's the, sorry, I didn't hear the question well.
What approach you prefer in draining subperiosteal abscess or orbital abscess in pediatric patient, endoscopic or open?
In pediatric, I don't manage kids. My preference would be an open approach. So I drain it via Lynch-Howarth incision and drain it in that manner. I've done very little endoscopic sinus work in kids. It's probably a question that's best posed to the pediatric ENTs.
Okay, thank you.
Brilliant. Thank you very much, David. That's very good talk. It's a comprehensive covering of all the basic rhinology. Very good, excellent. I really enjoyed. Thank you. So let's
sorry, there was a question. There was another question, I think, from Afiq Slim, but it's gone away. Afiq, why don't you just put the mic on and ask again, because I just saw.
Hi, can you hear me?
Yes.
Hi. Is there a challenge for doing aspirin challenge test for someone if you're suspicious of aspirin-driven disease like Samster?
Yes, so if a person has AERD or NERD, there is a point of giving an aspirin challenge. So to do an aspirin challenge, you need to admit the patient, give them an increasing regimen of oral aspirin. Okay, so you give it to them in hospitals, or they get an asthmatic attack. They're in hospital and there's the backup required. And if the only scope of doing an aspirin challenge is one, to get a diagnosis, and then to treat it with ATAD, aspirin treatment after desensitization, which means you give them something like 600 milligrams aspirin for the rest of their lives. I don't do it because if you look at the individual studies in EPOS, only 1 out of 4 studies, so they all found that it's effective. Only 1 out of 4 studies looked at adverse events, and they had a 1 in 16. So of 16 patients, 1 had a severe upper GI bleed. So I wouldn't be able to sleep at night if I had patients on 600 milligrams aspirin daily for the rest of their life. So for that reason, I don't use it. I'm not really too keen on using it. But yeah, there is a scope. It is effective, it's evidence-based, and it does work. And potentially you could reduce the daily dose.
Thanks.
Great. Thank you. I think no more questions, and everyone says a great rhinology talk. Very good.
Sorry, I did have a question. I think a couple of us have asked this. So at what point would you do bloods and so forth to when you're working this patient up to differentiate between eosinophilic and non-eosinophilic CRS?
That's a really good question. So there is no biomarker that tells you, be it histological or blood biomarker, that tells you if the person has type 2 or non-type 2. So if I see a patient and the patient, on my first visit, I won't get any blood tests. If the patient has clinical signs and symptoms of, say, ECRS, so a patient with bilateral inflammatory looking nasal polyps, I'll just treat. I won't get a full blood count. I won't get an IgE. I certainly won't get specific IgE, also known as RAS, but correct term, specific IgE, and I won't get skin prick tests. So I'll just treat. If the patient then presents and treatment is seen again, and his disease is well controlled, I'll continue treating him with a maintenance intranasal corticosteroid and saline without getting any tests. If there's anything in the history that suggests you need a test, say a history of recurrent infections, you might want to check for immunodeficiency, or anything else that might push you that might warrant an investigation, then yeah, by all means get it. But in a, I'm going to call it a box standard patient, I would only get the test, get the tests if I'm going to step up their treatment from medical treatment, okay? And I'd get an IgE, I'd get a full blood count to check the eosinophil count. I would check, I would get specific IgE if they have allergic symptoms, and sometimes it's difficult to tell. All right, I would check for IgA, IgG, and IgD, so an immune screen, and also functional antibodies if there are symptoms of recurrent infection as opposed to just chronic CRS. Okay, so you can tailor your blood test depending on the patients, but I wouldn't suggest routine tests.
Thank you, that's really helpful. And I just have a second question as well, if I may. So when you're seeing these patients clinically, what subtle factors are you looking at the history? Because obviously one of the things when you're seeing a polyp patient is